Good afternoon to everyone. I'm audible and visible to all of you. Good afternoon. Yes. Now good, guys. Good. So let's begin with a PSM part 1. Okay. So all the information, everything, whatever you know about the topics that I will be discussing, write down in the comment section. Okay. And followed by that, if you have any doubts, feel free to ask. Okay. I'll be answering all the doubts. And in tomorrow's session, the part 2, day after tomorrow, we'll be having calculations. Along with that, all the recent updates, whether it's on MMR, CBR, CDR, all the recent updates we'll be discussing as well. Okay, let's begin, guys. Okay, so let's start the first question, first topic with the vitamins. Okay, the question is, a 40-year-old, a chronic alcoholic, presents with a shortness of breath, pedal edema and tachycardia. On examination, there is an elevated jugular venous pressure, JVP is elevated. There is a hyperdynamic precordium and the bilateral basal crepitations. Echo reveals that this is a case of a dilated cardiomyopathy with high cardiac output. Which vitamin deficiency is most likely diagnosis? So you have a patient coming to you, 40-year patient is alcoholic. Along with that, shortness of breath, edema, tachycardia, and echocardiography reveals that there is a dilated cardiomyopathy. Yes, you have already studied in the pathology as well. Yes, dilated cardiomyopathy is associated with the alcoholics. Yes, HOCM is associated with the young athletes, right? And which type of cardiomyopathy is associated with amyloidosis? So let's have an integrated session, because agar PSM ko directly hum pura PSM padhenge, so it will be a bit dry for you guys. So tell me, which cardiomyopathy is associated with the amyloidosis? That's gonna be restrictive cardiomyopathy. Okay, so 3 questions. If young athlete, okay, HOCM, if dilated, alcoholic, and if amyloidosis is there, that's answer is going to be restricted cardiomyopathy. Now you already know patient is alcoholic and dilated cardiomyopathy. This is associated with wet beriberi. Very good, whereof it's associated with wet beriberi, and the beriberi is due to the deficiency of which vitamin? It is due to the deficiency of vitamin B1. It is gonna be deficiency of vitamin B1. So yes, this is a diagnosis. What is the diagnosis? It is deficiency B1, and B1 causes beriberi. Okay. Now this beriberi have 2 types, as in the comment section one student has already said it is wet beriberi and it's dry beriberi. Okay, so wet is associated with cardiomyopathy. Wet is associated with cardiomyopathy, and dry is associated with neuropathy. Dry is associated with neuropathy. Is that clear? Is that clear to everyone? Is that clear to everyone? Yes. Now followed by that, now we'll understand all the vitamins, all the deficiencies of the vitamins. Clear? Okay. Now this alcoholic patient who have a vitamin B1 deficiency, we have 2 syndromes, neurocognitive, alcoholic induced neurocognitive disorders, we call them. We have Wernicke's encephalopathy and Korsakoff's psychosis. And one question they usually ask, most of the time the question has been asked, that alcoholic patient present to you, okay, with a symptoms of a triad, global confusion, ophthalmoplegia and ataxia. What is your classical diagnosis? Sir, classical diagnosis is B1 deficiency thiamine, and the condition is Wernicke's encephalopathy. The condition is Wernicke's encephalopathy. Is that clear? And if a patient is having a features like, if a patient is coming with a features like amnesia, retrograde amnesia or confabulation, your answer goes to, write down in the comment section, your answer goes to Korsakoff's psychosis. Your answer is Korsakoff's psychosis. Is that clear? Is that clear to everyone? Yes? Chalo. Now let's discuss all the vitamins. What are the deficiencies? Okay. What are the symptoms? Okay, because vitamin chapter is very important. Chalo. Now first thing, sir, this vitamin B1 deficiency, it's usually seen in the polished rice eaters. Write it down. It's usually seen in polished rice eaters. Okay, the deficiency of vitamin B1, it will cause beriberi. It will cause beriberi, and I've already told that if it's a wet beriberi, think of a dilated cardiomyopathy, think of a cardiomyopathy. Okay, and if it is a dry beriberi, think of a neuropathy, think of a neuropathy. Okay, followed by that, sir, in alcoholics, it causes a neurocognitive disorder. In alcoholics, it causes two conditions. Number first condition is Wernicke's encephalopathy. Wernicke's encephalopathy, and number second is Korsakoff psychosis. Number second is Korsakoff's psychosis. Number second is Korsakoff's psychosis. Okay, now you already know the symptoms of a patient having a Wernicke's encephalopathy. Kya symptoms hote hain? Sir, there is a classical triad. We have a classical triad for Wernicke's encephalopathy, that is GOA. What are the three things? G-O-A. G is gonna be global confusion. O is ophthalmoplegia, and A is ataxia. And A is ataxia. Very good. Global confusion, ophthalmoplegia, and ataxia. Your diagnosis is going to be Wernicke's encephalopathy. Okay. Now the question was asked, which of the following symptom will be first corrected? Which of the following symptom will be first corrected after the infusion of a thiamine? Now you know the patient having a Wernicke's encephalopathy, the treatment is going to be IV thiamine, okay, followed by glucose. Remember first thing that first we give. पहले क्या देते हैं बच्चे? सब पहले thiamine देंगे. Followed by that we'll give a glucose. Followed by that we'll give a glucose. If in case we give glucose first, अगर आपने glucose पहले दिया, okay, so what will happen? The thiamine levels are already decreased, so it will have more depletion of the thiamine levels. Jab thiamine levels will further more decrease, patient will have further more confusion, patient will have further more ophthalmoplegia, and patient will have further more ataxia. So what is the first thing? What is the first thing? So first, the treatment is thiamine followed by glucose. And the question is asked that which of the following symptom will be first corrected? सबसे पहले क्या होगा? The order of the symptoms is GOA, and when it will be corrected, जब thiamine देंगे तो it will be corrected as OAG. Remember that. First ophthalmoplegia, followed by that ataxia, then confusion. Is that clear? Is that clear? Yes. And the two more symptoms of an Korsakoff psychosis will be retrograde amnesia, followed by that there will be confabulation. ठीक है ना? These two symptoms. And what will be the treatment? Treatment is, I'm writing here, treatment is IV thiamine plus treatment is glucose. So first thing, what I am writing first, I'm writing first IV thiamine. So remember, sir, we'll give thiamine first, followed by the glucose. If I'm giving a glucose first, it will cause more depletion of a thiamine, and depletion of the thiamine more, it will cause more symptoms like like global confusion, ophthalmoplegia, and ataxia. This OAG, what is this? So first ophthalmoplegia will be corrected, second ataxia, and third confusion. Okay. Followed by that, how can we prevent this thiamine deficiency? We should do the parboiling of rice. So we should go for the parboiling of rice. Is that clear to everyone? Yes. So thiamine deficiency, so cardiomyopathy, alcoholics, dry with cardiomyopathy, wet with the cardiomyopathy, dry with the neuropathy. It's seen in a polished rice eaters, Okay, deficiency will cause beriberi. Alcoholics, it cause the Wernicke's encephalopathy and Korsakoff psychosis. The treatment is going to be thiamine first and then followed by that glucose. So if I'm giving a glucose first, it will cause a more depletion of a thiamine, which will cause more symptoms of Goa. Okay, followed by that, Korsakoffs will have two symptoms: retrograde amnesia and confabulation. Remember, after giving a drug, after giving IV thiamine, what is the first symptom to be corrected? Ophthalmoplegia, followed by that ataxia, followed by that glucose. Okay, so followed by that global confusion. Okay, this is all about the thiamine. Okay, next is gonna be riboflavin. Riboflavin deficiency causes ariboflavinosis. Ariboflavinosis. Now, what exactly is this ariboflavinosis? It has a classical triad. Three things. What are the three things? Write down in the comment section. So three things are, first one is going to be angular stomatitis. Angular stomatitis. Number second one is going to be chiliosis. And number third is going to be geographic tongue or glossitis. Okay, which is also called as geographic tongue, which is also called as geographic tongue. Clear to everyone that? Yes, so that is riboflavin, ariboflavinosis, ariboflavinosis. Clear? Ariboflavinosis and thiamine. Third one is gonna be niacin. Niacin, repeatedly asked question, guys. Niacin deficiency will cause pellagra-like symptoms. Okay, it will cause pellagra-like symptoms. Tell me, my dear students, which amino acid? Which amino acid? Okay, niacin is derived from which amino acid? Okay, so whenever a case of a niacin deficiency will come, they can ask the case of an tryptophan deficiency as well, because you know that this niacin is coming from which amino acid? The amino acid is tryptophan. It is tryptophan. Okay, tryptophan. What is coming, guys? Sir, niacin. Okay, serotonin and melatonin. Okay, serotonin, melatonin, and niacin is coming from tryptophan. Okay, melanin and epinephrine, norepinephrine, catecholamines, they are coming from the tyrosine. Remember, they are coming from tyrosine. Okay, chalo. Now, what are the features? So we have 6 Ds. So we have 6 Ds. So what are the 6 Ds? Write down. We have diarrhea. We have dermatitis. We have diarrhea, dermatitis, dementia, delirium, depression, and death. So these are the 6 Ds. These are the 6 Ds of a pellagra symptoms. Okay, this is a classical case. This is angular stomatitis here in the image. Okay, this is a causal neck, and this question has been asked. Okay, what is the deficiency? Deficiency is niacin deficiency, or you can write, so it's also tryptophan deficiency if they come. Okay, chalo, followed by that we have a B5 pantothenic acid. Okay, now first three B2, B1 and B3, very repeated questions. Okay, B5 is a pantothenic acid, and deficiency of B5 will cause the soul syndrome or burning feet syndrome. So it will cause soul syndrome or burning feet syndrome. It's also called as soul syndrome. Okay, followed by that we have pyridoxine. Okay, pyridoxine deficiency will cause peripheral neuropathy. It will cause peripheral neuropathy. Okay, and B6 deficiency is also due to one drug, anti-TB drug. What is the name of the drug? Anyone? What is the name of a drug? What is the name of the drug which anti-TB drug causes B6 deficiency? Which anti-TB drug causes B6 deficiency? Your answer is going to be isoniazid. Your answer is going to be isoniazid. Isoniazid causes B6 deficiency. That's why whenever we are giving isoniazid, we give pyridoxine along. Number first thing. Number second thing is other anti-TB drugs. Remember, if we talk about ethambutol, it causes optic neuritis. Ethambutol causes optic neuritis. Isoniazid causes peripheral neuropathy, B6 deficiency. Pyrazinamide causes hyperuricemia. So the patient will complain of patient will have a gout. Usually it's asymptomatic gout which is seen with the pyrazinamide. Okay, rifampicin will cause a orange color secretions, and less likely streptomycin, which is an injectable aminoglycoside, it will cause ototoxicity. Remember these side effects of an anti-TB drugs. Followed by that, biotin will cause, if we talk about biotin will cause alopecia. Biotin will cause alopecia, and usually if the question will come, PYQ was asked, it is seen with raw egg consumers. Those who are consuming raw egg, it is seen with them. Followed by that, we have folic acid. Folic acid deficiency will cause megaloblastic anemia. Folic acid deficiency will cause megaloblastic anemia. Okay, and also folic acid deficiency in pregnancy will cause, if I'm talking about pregnancy, in pregnancy it causes neural tube defects. In pregnancy it causes neural tube defects, and I've already discussed most common neural tube defect is going to be spina bifida. Most common neural tube is going to be spina bifida. If a question is most common spina bifida, it's going to be spina bifida occulta. Okay, that we have already discussed. Now there are two signs seen in spina bifida, that is called as lemon sign and banana sign. Lemon and banana sign in the cerebellum. Lemon sign and banana sign. Okay, other neural tube defect we have talked about anencephaly having two signs, Mickey Mouse sign and the frog eye sign. Mickey Mouse sign and the frog eye sign. Clear? Okay, now the presence of acetylcholinesterase in amniotic fluid will also tell me about this neural tube defect. Okay, now this megaloblastic anemia is also caused by one more vitamin deficiency, vitamin B12, which is called as cyanocobalamin or the cobalamin. Okay, now deficiency of B12 will, again write it down, will cause megaloblastic anemia. So it will cause megaloblastic anemia, number one thing. Number second thing is, it will also cause, because this B12 helps in the preparation of the myelin sheath, so it also, if the deficiency of B12 is there, it causes subacute degeneration of myelin. Okay, it causes subacute degeneration of myelin sheath. Okay, and one more thing, remember, if a classical case will come that B12 deficiency is there, it will mention it is seen with strict vegetarians. Is that clear? Now my dear students, if a question comes that now the patient is having a folic acid deficiency or the patient is having a B12 deficiency, now you already know that both of these two vitamins will cause a megaloblastic anemia. Now based upon the symptoms, how you can diagnose, not based upon a MMA levels or not based upon the homocysteine levels. I know that you go for the investigations and you check whether a patient is having increased homocysteine levels or normal, whether the patient is having increased MMA levels or normal. But tell me, on the basis of a clinical features, how you can differentiate that the patient is having the megaloblastic anemia due to the folic acid or the megaloblastic anemia due to the vitamin B12. Remember, I've already mentioned that the patient is having a subacute degeneration of myelin due to the vitamin B12 deficiency. So whenever the neurological deficit features are there, and anemia is there, megaloblastic anemia is there, think of a vitamin B12. Okay, neurological deficit features associated with the B12. If not, then it's gonna be folic acid. Okay, we also check the levels. What are the levels we check? We check the MMA levels and homocysteine levels. Now tell me, in case of a folic acid deficiency, now tell me, in case of a folic acid deficiency, what will be the levels of a MMA and homocysteine? In case of a folic acid deficiency, jaldi, in case of a folic acid deficiency, what will be the levels of, in case of a folic acid deficiency, what will be the level of MMA and homocysteine? Anyone in the comment section? If yes, if MMA levels and homocysteine levels both are increased, if both increased, what will be your answer? Which type of anemia is that? If both will be increased, what will be your answer? If both MMA and homocysteine level are increased, what will be your answer? We usually confuse. So if both of them are increased, the answer is gonna be, write down in the comment section, guys. If both of them are increased, what will be the answer? Very good. The answer goes to B12. The answer goes to B12. Okay. If one is normal, okay, homocysteine is normal, then the answer goes to B9. Very good. Okay, so that is based upon the investigation. If based upon the symptoms, neurological deficit features, so that I will mark answer as a B12. Okay, that I will mark answer as a B12. Now, how much of folic acid to be given, how much of iron to be given, I will be discussing that as per the anemia book Bharat and as per the Government of India. Okay, now vitamin C deficiency will cause, write down, vitamin B deficiency will cause scurvy. Okay, vitamin B deficiency will cause scurvy and it will cause delayed wound healing. It will cause scurvy and delayed wound healing. Okay, what is the requirement? 40 mg per day. The requirement is 40 mg per day. Okay, if we talk about the richest source of vitamin C, that's going to be amla, called as Indian gooseberry. Indian gooseberry. Okay, followed by that, if we talk about the vitamin D, the most active form of vitamin D is 1,2,5 dihydroxy cholecalciferol. 1,2,5 dihydroxy cholecalciferol. 1,2,5 dihydroxy cholecalciferol. Okay, this is a classical picture given of a scurvy. Okay, now tell me, my dear students, if there is a gum hypertrophy given in an image and it said patient is having gingivitis, which drug will cause a gingivitis? Which drug will cause the gingivitis? Hyperplasia of the gums or gum hypertrophy is a classical side effect of a which drug? Phenytoin. Remember that it's a classical side effect of a phenytoin, but phenytoin in pregnancy causes fetal Head-and-Twine syndrome. Remember that. Okay, चलो आगे बढ़ते हैं. Deficiency in children's having a vitamin D deficiency will cause rickets, and in adults it will cause osteomalacia. In adults it will cause osteomalacia. Okay, osteomalacia. One more question was asked in the PYQs. Remember that this vitamin D, it is important for the calcium absorption. It's important for the calcium absorption. Okay, now if the vitamin D is decreased, eventually what is happening to the patient? Hypocalcemia. And indirectly it was asked that which of the following vitamin deficiency will cause from the ENT laryngospasm. Okay, so exactly they did not mention the laryngospasm. The wording was like laryngismus stridulus. क्या पूछा था बच्चे? So they asked laryngismus stridulus. So which vitamin will cause laryngismus stridulus? Okay, sir, vitamin D, due to the decreased calcium. जब calcium होता तो vasospasm like features, hypocalcemia. Okay, so patient is having a laryngospasm. Is that clear? Yes. And hypocalcemia mein we have two more signs. What are the two more signs? Yes, what are the two more signs? When a patient is having a tumor lysis syndrome, let's integrate a bit. Patient is having a tumor lysis syndrome. ओके तो वहाँ पे क्या होगा, हाइपोकैल्सीमिया होता है पेशेंट को. देयर आर टू साइंस. व्हाट आर द टू साइंस? वी आर हैविंग carpopedal spasm, causes sign, and one more we have choastic sign. Is that clear? Is that clear to everyone? Vitamin D. Clear? Yes. So what is the richest source? What is the richest source? It is halibut oil. The richest source is, my dear students, halibut oil. Clear? Now if we talk about vitamin E, which is tocopherol, and vitamin E has a property, it is antioxidant. It is antioxidant. The question from vitamins, usually they don't ask the normal questions anymore, okay? They ask in the form of a clinical cases. Is that clear? Okay, they usually ask the questions in the form of a clinical cases, okay? So make sure all the vitamins, 2-3 questions usually they ask, so that you study these vitamins in a depth, because biochemistry point of view vitamin question will be also asked bache, and also from the PSM point of view. Now richest source of vitamin E is the wheat oil. Richest source of vitamin E is wheat oil, and this causes the hemolytic disease of newborn. So it causes hemolytic disease of a newborn. Okay, talking about vitamin K. Vitamin K deficiency, you already know that it causes hemorrhagic disease of a newborn. It causes hemorrhagic disease of a newborn. Okay, now vitamin K से मुझे याद आया one more question, that tell me, my dear students, which milk is deficient of vitamin K? Cow milk or breast milk? Which vitamin K is deficient in which type of milk? Cow milk or the breast milk? Remember, it's breast milk. Okay, cow, C for cow, C for vitamin C. So vitamin C is deficient in the cow milk. Okay, now vitamin K has two forms. One is natural form, okay, and one is synthetic form. The natural form is fat soluble, and synthetic form, it's water soluble. It's water soluble. Now what is K1? Three forms: phylloquinone, K1 is phylloquinone, and K2 is menaquinone, and K3 is menadione. K3 is menadione. That's why, and also once a baby is born, we give a intramuscular vitamin K injection, because it can cause hemorrhagic disease of newborn in infants, and in adults it causes bleeding as well. It causes bleeding as well. Clear? This was all about the vitamins. This was all about the vitamins. Okay, so alcoholic patient, cardiomyopathy, classical case of a beriberi. Okay, wet beriberi causes that, and dry causes neuropathy. Usually Wernicke's encephalopathy. Remember GOVA, और करेक्ट कैसे सिम्टम्स होते हैं? OAG, ophthalmoplegia, ataxia and global confusion. Okay, followed by that, remember the riboflavin. Okay, remember that first we give the thiamine IV, followed by that we'll give the glucose, remember niacin, pellagra, tryptophan, 6Ds, pantothenic acid, burning face syndrome. Remember, this has been asked multiple times. Okay, pyridoxine deficiency, peripheral neuropathy, caused by the drug isoniazid as well. Okay, then pernicious anemia as well, folic acid, megaloblastic anemia, pregnancy, neural tube defects. Okay, B12, cyanocobalamin, megaloblastic anemia, subacute degeneration of the myelin, and then vitamin C, scurvy. Okay, richest source is amla. Vitamin D, rickets and osteomalacia. Remember, laryngospasm, decreased calcium, decreased vitamin D, laryngismus, stridulus. Okay, vitamin E, antioxidant, hemolytic disease of newborn. Vitamin K, hemorrhagic disease of newborn. Okay, natural form, fat soluble, synthetic form, water soluble. Okay, remember, selenium deficient will cause Cation's cardiomyopathy. Okay, selenium deficiency, Cation's cardiomyopathy. Zinc deficiency will cause acrodermatitis, enteropathica. Okay, and copper deficiency, you already know, copper deficiency will cause Menkes disease. Okay, so copper, zinc and the selenium. Copper decreased, Menkes disease with the features of kinky hair, and patient is also having retardation in case of a Menkes disease, kinky hair with mental retardation. The enzyme deficient is lysyl oxidase. The copper is decreased, Menkes disease. Selenium, Cation cardiomyopathy, but if selenium is excess, it is Cation-Bach's disease. And one more condition, guys, zinc deficiency causes delayed wound healing. Okay, delayed wound healing. And zinc deficiency also cause implants में ectodermatitis enteropathica. Okay, gum means it will be sticked like this, but it is this, it is rum. Okay, rum and gum, mnemonic syndrome. Okay, gum means close, rum means away. So bottle cap is away, that is where rum. Okay, gum means if it's closed, stick together. So gum is चिपक जाता है. Clear? Now one more question. Following are the primary signs in WHO classification of xerophthalmia, except now you already know that vitamin A deficiency will cause xerophthalmia, and we have WHO signs, primary signs and secondary features. Now which of the following is not a primary sign? Okay, now let's discuss vitamin A question, that vitamin A deficiency will cause xerophthalmia. Vitamin A deficiency will cause xerophthalmia. Now WHO has primary signs. What are these primary signs? Write it here. What are the primary signs? First of all, we have X1A, which means conjunctival xerosis, dryness. Then we have X1B. It's the most common clinical sign of a vitamin A deficiency, called as Bitot spot. We have X2 called as corneal xerosis. We have X3A, corneal ulcer or scar. X3B called as keratomalacia. These are all, sir, the primary signs. These are all the primary signs. Now if we talk about the secondary features, we have three secondary features. N, which is the most common symptom, night blindness, the first symptom. Night blindness. We have XF, xerophthalmic fundus. And we have XS called as xerophthalmic scar. Now question has been asked that which of the following, okay, all of the following are the primary signs except. So what will be your answer? All of the following are the primary signs except your answer is night blindness. It's a secondary feature. It's a secondary sign. Clear to everyone? Yes. Now sir, what is the first symptom of the vitamin A deficiency? Write it down. The first symptom is night blindness. The first symptom is night blindness. If you call the first sign, that is going to be conjunctival xerosis. The first sign is conjunctival xerosis. If you talk about most common clinical sign for the screening, that's X1B, Bitot spot. The most sensitive screening test, serum retinol levels. Okay, and then sources. If we talk about the richest animal source, it is halibut oil. Second richest is liver oil. And from the vegetables and fruits, we have carrot, and papaya. Yeah, carrot and papaya. This was all about vitamin A. Now the prophylaxis vitamin A deficiency. So doses. If we talk about total doses, we have total of 9 doses. We have total of 9 doses. The total amount, if we talk about the total amount, we need to give 17 lakh international units. The first dose is around 9 to 12 months. And second to 9 dose you'll give every 6 months. Every 6 months till 5 years. Till 5 years. Okay. Now if we talk about the dosage, okay, the question was asked that the age of the baby is 13 months. How much of vitamin A will be given? You know that yes, after 12 months, more than 1 year, it's 2 lakh international units, right? They ask 2 lakh international units IV, 2 lakh international units IM, 2 lakh international units orally, 2 lakh international units nasal, intranasal. So what is your answer? Remember 2 lakh you remember, but more important is remember it's orally. Okay. Sometimes we often make silly mistakes. Okay. All of you will easily pass this exam, but you must focus on the silly mistakes. Don't go for the silly mistakes. So less than 6 months. Now usually we give around 9 to 12 months. Okay. Now if a patient is having a vitamin A deficiency and less than 6 months, give 50,000 international units. Okay. 6 to 12 months, sir, 1 lakh international units. More than 1 year, it's 2 lakh international units. Okay. But if the weight of the baby is less than 8 kg, then they give only 1 lakh international units. We give 1 lakh international unit. And remember, 1 ml of vitamin A is equal to 1 lakh international units. Okay. So it's all about the vitamin. It's all about the vitamin A deficiency. Yes, you will get the PDF. I'll share the PDF in MeduHub channel. Okay, guys. Ramesh. Now, followed by that, if the image-based question will come, what is this for me? Deposition here. It is bitot spot. Bitot spot. Okay. In deficiency, हाँ question आएगा कैसे दोगे on day 0, day 1 and day 14. The schedule of a vitamin A 0, 1, 14, or you can write 1, 2, 14. Okay, 1 will be the present day, then day after, then tomorrow, and then 2 weeks post. Clear? Okay, bache. Now it was all about the vitamins. It was all about the vitamins. They can even ask, as per the primary signs, the bitot spot is X1B. Remember, guys, it's X1B. Okay, X1B. Okay, if X3B is that is keratomalacia. 1 is, remember this way, 1 is the most common clinical sign. So first clinical sign kaun sa hai? Bitot. So you will remember X1B. Okay, so that was all about the vitamins. Okay, remember there are only three secondary features: night blindness, xerophthalmic scar, xerophthalmic fundus. Okay, only these three: xerophthalmic scar, xerophthalmic fundus, and night blindness. Okay, now next question: which of these is the correct dosing schedule according to the given program logo? Okay, these are all the PYQs mostly, but it's not the previous year question that is important, it is the previous year topic. Okay, so last time they usually ask the pregnant lady. What if this time they will ask about the adolescent? What if this time they will ask about the age 3 years, 5 years? Okay, now the given logo is of a Anemia Mukt Bharat. Okay, this Anemia Mukt Bharat was launched so that we decrease the prevalence of an anemia in the country. Okay, and as per this logo, as per the scheme, there are 6 beneficiaries, 6 institutional mechanisms, and 6 interventions. Okay, 6 into 6 into 6 strategy. The question was also asked, what is a 6 into 6 into 6 strategy? Okay, so remember that 6 into 6 into 6 strategy is Anemia Mukt Bharat, where 6 beneficiaries, 6 age groups, 6 interventions. Okay, and 6 institutional mechanism. Now you already know that folic acid in pregnancy is important because it prevents the neural tube defect. It prevents the neural tube defect. Now we'll learn that as per Anemia Mukt Bharat, how much iron to be given, and as per the normal norms, how much iron and folic acid to be given. Okay. Now if we talk about the 6 months to 5 years age group, 6 months to 5 years, the amount of iron given is 20 mg and amount of folic acid is 100 micrograms. And what will be the frequency? Sir, twice a week or bi-weekly. Twice a week. Okay. Now if a age group between 6 years to 10 years, if the age group is between 6 years to 10 years, how much of iron to be given? 45 mg of iron to be given. How much of folic acid to be given? 400 micrograms. Okay, and you have to give this weekly. You have to give weekly. Okay, next, if age group between 10 years to 19 years, if age group between 10 years to 90 years, the amount of iron given is 60 mg and amount of folic acid to be given is 500 micrograms, and the frequency of this will be again weekly. Okay, next, if a age group between 19 years to 49 years, 19 years to 49 years, what will be the iron dosage? It will be 60 mg of iron. What will be the folic acid? It will be 500 micrograms of folic acid. Again, it's going to be weekly. Okay. Now followed by that, if asked about pregnancy and lactation, my dear students, sir, if asked about pregnancy and lactation, make sure you remember that in pregnancy, it's going to be 60 mg of iron, 60 mg of iron and 500 micrograms of folic acid, 500 micrograms of folic acid, but the frequency will be daily. Frequency will be daily. Okay, so yes, you all are right. So as per this given logo, we have to give 60 mg of iron and 500 micrograms of folic acid to the pregnant lady daily. Okay, now if a question, it's as per the Anemia Mukt Bharat. ये किसके वजह से? Sorry, it's as per the Anemia Mukt Bharat. If asked normally, guys, if a normal lady, not as per the Anemia Mukt Bharat, we give 100 mg per day iron. Okay, in pregnancy. If asked mild to moderate anemia, okay, mild to moderate anemia, तो कितना देंगे? Then we have to give the 200 mg for mild to moderate anemia in pregnancy. One thing. Second thing is how much of folic acid to be given? 400 micrograms per day. That is folic acid. That is folic acid. Clear? That is folic acid. Now one more question, my dear students. If a patient is having a history of neural tube defect, if a patient is having the history of neural tube defect, how much of folic acid to be given? Write down in the comment section. Sir, the folic acid given is 4000 micrograms per day. या तो वो लिख सकते हैं 4 grams per day. This is about a patient having a history of neural tube defect. If patient is having sickle cell anemia, तो 5000 micrograms. Then 5000 micrograms. Yes, Ramesh, I've already discussed that neural tube defect is there. You give the 4000 micrograms per day. Okay, and normally not as per the Anemia Mukt Bharat, तो iron कितना दोगे? 100 mg per day in pregnancy, and folic acid to be given is 400 micrograms per day. Okay, now remember guys, I've already discussed in OB-GYN as well that which worm can cause iron deficiency anemia. You already know this, that in case of a pregnancy, anemia in pregnancy, we deworm the patient as well. Okay, what we give, what is the deworming agent? We give albendazole, because yes, which worm can cause Which worm can cause the iron deficiency anemia? That is hookworm. Hookworm can cause iron deficiency anemia. Hookworm can cause iron deficiency anemia. Which worm can cause megaloblastic anemia? Fish tapeworm, Diphyllobothrum latum. Fish tapeworm will cause megaloblastic anemia. Remember that as well, these two conditions as well. Clear? Chalo. So this was all about the anemia mukt Bharat. Clear to everyone? Yes. Can we move to the next part? Sorry, can we move to the next question? Yes. Chale. Next question from the epidemiological study. Okay, all the questions related to the calculation I will do the part 2. Okay, so let's understand the question. A study was conducted on a group of 500 patients having a carcinoma lung, and another group of 300 was chosen from the general population. Both of these groups were questioned on their exposure to smoking. What kind of study is this? What kind of study is this? Now, thank you so much, sir. Okay, you guys got this. Exam is coming and you are absolutely gonna pass this exam. Okay, and whatever doubt you have, I'm myself a foreign medical graduate, so whatever doubt you have, ask me. I know we have silly doubts as well, we have hard doubts as well, whatever there is. Okay, be the best. Okay, be the best, try to be the best. Medicine is so vast, there is nobody 100% perfect in this medicine, because even if we'll study this 19 subjects all our life, there are books in the books. Okay, all the topics we are studying in these journeys, there are books written in these topics. Okay, but yes, whatever we can accumulate to pass this exams. Okay, we don't need to know every single thing, but yes, we should know enough to pass this exam. Okay, then eventually things will be coming up. Okay, that's what is coming. Okay, epidemiology is coming only. Okay, so be like, trust yourself that whatever you are studying, this is gonna be beneficial for you, and you are eventually gonna pass this exam and you're gonna be the best doctors for sure. Okay, believe in yourself. Chalo. Now, a study was conducted on a group of 500 patients having a carcinoma lung, and another group of 300 was chosen from the general population. Okay, both of these groups were questioned on an exposure to smoking. Now, right now, the disease is present. Very good, all of you. That right now the disease is present, and you are going back in time. Okay, so from the present to the past, from the disease to the risk factor. Okay, from the disease to the risk factor, this type of study is called as, very good, it is called as case control study. This type of study is called as case control study. Now listen to me, my dear students. First of all, epidemiology. So what is epidemiology? Epidemiology is the study of distribution, it's study of frequency, it's study of the determinants of a disease, that how this disease is caused, distribution, time, place and person. Followed by that, sir, what is the incidence, frequency of this disease, incidence and prevalence, and what are the causative agents of a disease, and what exactly we can do to control this particular disease. This is called as epidemiology. Then if we go for the classification of this epidemiology, first of all, we need to build the hypothesis. So from the time, place and person. For example, some disease occur in a particular time, okay, with to a particular place. Kala Azar, Leishmaniasis is usually seen in West Bengal or Bihar. Okay, particular person, breast cancer usually in the females, lung cancer usually in the males. Are you getting my point? So that's how we make a study first. Now when the hypothesis is created, then we need to test these hypotheses. Then how accurate, how correct these hypotheses are, we go for the following studies. Now what are those studies? That's what we are going to discuss. Cohort study, cross-sectional study, ecological study and case control study. Are you getting my point? So we are going to study whether the risk factor is associated with the disease or not. Okay, for instance, I am taking a study on a lung cancer. So there are 10 people who are smokers. Now I'm going to check whether these 10 people after smoking for 10 years will develop the lung cancer or not. Okay, so for 10 years I'll be studying on them. For 10 years I'll be going for the investigations. For 10 years I'll be checking whether these 10 people who are smoking will develop the lung cancer or not. After 10, after the 10 years, when I'm seeing out of all these 10 people, there were only 5 people who developed the lung cancer. So I will check what will be the incidence of developing the lung cancer in a people who are smokers and people who are not smokers. Okay, I will show you some basic questions, how to calculate this, what is a relative risk, what is incidence, what is odds ratio. This all will do in the calculations, but prior to that you need to understand what exactly this study means. So if this is a present time, okay, if I am going in the future, forward study. If I'm going into the future, that is a forward study. So 2025, I'm here right now and I'm doing a study on the 10 people who are working in an glass factory, who are working in the coal industry. Okay, now you know that pneumoconiosis, you know the occupational disease, you know the people who work in the stone industry, they are more prone to which type of pneumoconiosis? Silicosis. So I'm waiting for how long they will develop the silicosis. Then I will say that how often they will develop what? Tuberculosis or silicosis. Then I will say that what is the risk of people who are working in a stone industry, who are working in a cement industry, how much risk it is there, so that they will develop the silicosis. So I will have a time, okay, risk. So I'm going in the future, I'm going in the forward direction. So when any study you are going in a forward direction, that study is called as cohort study. Pehle basic, okay, pehle basic samjho. But if a patient is coming to me and patient is having cirrhosis or the liver cancer, what is the first question you will ask? First question you will ask, are you alcoholic? So patient will go back in time. So when patient goes back in time, when a disease is present and you try to find the risk factor, that type of study is called as case control study. So future mein cohort, past mein case control. Is that clear? And if a study is done at the point time, not forward, not backward, that is called as cross-sectional study, also called as snapshot study. Now when you take the picture of anything, the picture only tells you about the present. Picture will not tell you what are the actions before the picture, what were the actions after the picture. Okay, it will just tell you an accurate at the present time. That's called as cross-sectional study, which is done at a given point, okay, neither forward nor backward. That's why it's also called as cross-sectional study. It will tell me about the prevalence of disease. And then the study that you usually do on the nutritional surveys, that this type of population, for example, in pregnancy 350 kilocalories are needed, okay, in lactation 600 kilocalories more are needed. So for that particular study we do a ecological study, which will tell me about the characteristic of a population, which is done usually on the nutritional surveys. So that type of a study is called as ecological study. So in short manner, my dear students, so we have 4 studies usually: cohort, forward direction, case control, backward direction, at given point, cross-sectional, telling me about the population characteristics. It is ecological study. Is that basics clear? Very basics, bache. So what is epidemiology? So epidemiology is the study of distribution, frequency and determinants of a disease and the ways to control that particular disease. Is that clear? Is that clear? Yes. So here guys, patient is already having a disease, carcinoma lung, okay, and you are going back in time to check whether there is an exposure to smoking or not. Okay, so which type of study is that? So that is simply a case control study. Now this association, okay, the strength of association is given by the following factors. Okay, now what are we checking? In cohort study we'll be checking incidence, relative risk, population attributable risk. Okay, cross sectional mein we'll go for the prevalence. Case control mein we check the odds ratio or cross product ratio, which will tell me, all these things will tell me whether the association of risk factor is there or the association of risk factor is not there, or there is negative association. That means sometimes the risk factor is a protective, depending upon the value of an odds ratio. So here simple thing, they go back in the time, asking about the history, disease is present, they go to the risk factor. This study is called as case control study, and we usually check odds ratio in the case control study. Calculation based on this I will do all the calculation, whatever they can ask. Clear? Now, what is case control study? Sir, it is also called which study? Backward or forward? Sir, it is also called as backward study. It's also called as backward study. That means it is study from the disease. So disease is present, you go back in time, you try to find out the risk factors. So it is also called as retrospective study. It is also called as retrospective study. Clear? Followed by that, it is also called as effect to cause study or outcome to exposure study. Outcome is already there, answer is already there, the patient is having a disease. Okay, so you go back in time. Yes, retrograde. So you go back in time. It is very fast study. Why? Because you don't need a follow-up and there are no nerve cases. Now for the cohort study, you have 10 people who are smokers, so you need to wait for at least 10 years. But because it's not like first year they are smokers and next year they will develop the lung cancer, no. So you need to wait. Okay, you need to wait then for 10 years, so that, and you need to wait for the people follow up. Okay, it will be expensive as well, because every year you need to go and check for the investigate, you need to do investigation in order to check whether the fibrosis is there, whether the damage is there, okay, whether any lesion is there formed. Okay, so you need to go for the investigation. That's why the cohort is expensive. But in case of a case control, so it is expensive? No. Is it slow? No, it's very fast because outcome is already present over there. We don't need any follow-up, but same time the disadvantage of cohort is you need to do follow-up. Kabhi you can even lose the follow-up, you can even lose the subject. Okay, that we will learn what are the classical differences between cohort study and case control, what is attrition, what is bias, what is confounding. Okay, chalo, no nerve cases. It is also known as opposite of cohort. It is also known as Trohak study. It is also known as Trohak study, and the strength of association is given by odds ratio or cross product ratio. The strength of association bache will be given by odds ratio or cross product ratio. So it's about case control. It's about case control study. Clear? It's about case control study. Chale, next. Now we have indicators of a quality life. Okay, all the calculations, don't worry, we're gonna do one by one by tomorrow. Okay. Chale. Now physical quality of life include the following parameters. Okay, this is the NEET PG PYQ, but sir, इतना आसान उन्होंने पूछा था? No, the way they asked was a bit different. I will tell you the way how they exactly asked the question. So we have indicators of a quality life. Okay, usually main two indicators we have physical quality of life index and human developmental index. So what are the two? Physical quality of life index and the human development index. Okay, now what are the components of a physical quality life index, PQLI? We have three components. What is the first component? So we go for life expectancy at 1 year. Life expectancy at 1 year. Okay, that is number one. Okay, then literacy rate. Literacy rate. Ashwini Eji, is this enough? I cannot say yes, this is enough, but at least if you have studied your primary notes for revision, okay, for revision, it's good. It will help you a lot. Okay, we can never trust NBE. They can ask anything from anywhere, but I have included all the topics based upon the recent NEET PG PYQs and FMG PYQs. I have included the topics that they are asking multiple times. So I will not say the same questions will be repeated for sure. No, questions to repeat nahi hote, but the topics will be same. Okay, so we'll be trying to cover almost 30-40 topics in part 1 and part 2. Okay, and from the 40 topic, at least even if you get 15 to 18 questions, that is good number. Just in like 6-7 hours, if we are getting at least 50% of the question, that is good. But rest 50% of the questions you can integrate. Okay, you can go through your primary notes. Okay, that will be good as well. Okay, na? Chalo, literacy rate and we have infant mortality rate, and we have infant mortality rate. And we have infant mortality rate. Now my dear students, these three components are of what? Physical quality of life index. Now the question in NEET PG was asked that, see, which of the following are the parameters of PQLI except? Now except, what is your answer, sir? Except infant mortality rate, yes sir, it is there. Expectancy at the age 1, yes sir, it is there. Education or the literacy rate, yes sir, it's there. What exactly is not there is life expectancy at birth. What exactly is not there is life expectancy at birth, because this is the component of a human development index. This is a component of human developmental index. Okay, now option D is the answer. But in NEET PG the question was asked in a way, which of the following will define the PQLI? Your options are A, B, D, B, C, D, D, C, A, B, C. Are you getting my point, bache? So how was the question asked? So question was asked, which of the following will define the physical quality of life index? Okay, 4 options given, and then further 4 more options are given: A, B, D, B, C, D, DCA, ABC. So you know that infant mortality rate, life expectancy at age 1, and the education, they define the PQLI. Is that clear? Okay, so in a more advanced way they can ask, topic is same. Morning में उन्होंने PQLI पूछा था, evening shift last year they asked HDI. So make sure you remember this. Physical quality of life index having 3 components. Okay, having 3 components: life expectancy at 1 year, literacy rate, and infant mortality rate. Now what about the components of human development index? So we have life expectancy at birth, followed by that we have knowledge and income. These are the components of an human development index. Okay, now remember the range for the PQLI is 0 to 100. The range for HDI is 0 to 1. It's 0 to 1. Okay, followed by that the value of PQLI, old value 71, HDI 0.645. Okay, most developed country is said to be Norway, having the highest HDI. Okay, most developed is Norway. Chale guys, now literacy rate, we can use the other names as well, different synonymous as well. What are the other names that we have used for the literacy rate? One is already there, you saw the knowledge. We can mention knowledge as well. Okay, there can be educational index, and mean year of schooling. Good. Now followed by that, what are the other indicators, sir? Other indicators, we have human poverty index, which will tell us about the quality of life. These are the other indicators, human poverty index. Followed by that, we have human suffering index. Followed by that, we have multi-dimensional poverty index. Multi-dimensional poverty index. So it was all about the PQLI and HDI. Is that clear to everyone? Yes, write down in the comment section, please. All clear? Yes, sir. Chale guys, let's move to the next part. Okay. A 47-year-old man presents with the progressive shortness of breath. History of working in a quarry for 20 years. His chest X-ray shows the multiple small nodular opacities predominantly in the upper lobes. So it's a disease which usually affects the upper lobes. And the hilar lymph nodes show the calcification called as eggshell calcification. So the hilar lymph node shows which calcification, bache? Sir, they show the eggshell calcification. Okay, and what is your diagnosis? So let's discuss about the pneumoconiosis. Okay, pneumoconiosis are the respiratory disease which occur exposure due to dust, which occur due to the exposure to dust. Okay, now what are the different types of pneumoconiosis and what is the dust associated, we will learn. Okay, now in a clinical case they are working in a query for 20 years and it usually affects the upper lobes, and we have a classical calcification on chest x-ray called as eggshell calcification. This is the classical picture, guys. This is exactly what this is, exactly these eggshells. Okay, and this is a feature of which condition? This is a feature of a silicosis. This is a feature of silicosis. This is a feature of silicosis. Okay, now let's discuss what exactly is silicosis. Okay, now if I talk about the occupational disease, the pneumoconiosis, these are the respiratory disease which occur due to the exposure to the dust. And the dangerous particles, what is the size usually? It is 0.5 to 3.0 microns, and usually less than 5 microns, less than 5 microns. Okay, now if we talk about the first one, the most common pneumoconiosis is going to be silicosis. The most common pneumoconiosis is going to be silicosis. Okay, remember the dust associated with silicosis is silica dust. Silica dust or stone dust. Silica dust or stone dust. Okay, number second thing is the patient need follow up for tuberculosis, because the patient who are working in a stone dust industry, who are working in a cement dust and who develop silicosis, they are more prone to which opportunistic infection? They are more prone to which infection? Your answer is that they are more prone to tuberculosis. So continuous follow up for TB is needed as well. Okay, now if we talk about the classical feature of an X-ray, here it's an X-ray given, and in question they can mention the eggshell calcification. So eggshell calcification on hilar lymph nodes. Eggshell calcification on hilar lymph nodes is a classical feature of a silicosis. It's a classical feature of a silicosis. Okay, eggshell calcification on chest x-ray is a silicosis. But if it mentions popcorn calcification, अगर लिखा हुआ है popcorn calcification on chest x-ray, what will be your answer, बच्चे? Popcorn calcification on chest x-ray, what will be your answer for that particular condition? Sir, popcorn calcification on chest x-ray is going to be pulmonary hematoma. It's going to be pulmonary hematoma. Okay, and pulmonary hematoma is the most common benign tumor of the lungs. It's going to be the most common benign tumor of lungs. Okay, pulmonary hematoma. Okay, now if the popcorn calcification on mammography, that you already know, a 30-year-old female with a mobile mass, usually what is the answer? Answer is fibroadenoma. Okay, fibroadenoma. Clear to everyone? Yes, so remember popcorn calcification on chest x-ray is pulmonary hematoma, and pulmonary hematoma is going to be the most common benign tumor of the lungs. Okay, this classical x-ray is given. What is an appearance called as? So this is called as snowstorm appearance. This snowstorm appearance is also associated with silicosis. So it is also associated with silicosis. Clear? It is also associated with silicosis. So two features if they can ask. Okay, x-ray mein eggshell calcification, silicosis, and snowstorm appearance, silicosis. Remember, it usually affect which lobes? Upper lobes is the hint. One more hint, please do remember, upper lobes is the one more hint. Okay, followed by that second one is asbestosis. Now asbestosis, you already know that it's the only pneumoconiosis. Sir, it's the only pneumoconiosis which is associated with malignancy. It's the only pneumoconiosis associated with malignancy. Associated with malignancy. Okay, now it is associated with asbestos dust. Asbestos dust, and we have a classical bodies seen in the asbestosis. Asbestos body, or what is the another name? Write down in the comment section, anyone. What is an another name? Very good. What is an another name? Yes, construction, shipbuilding industry and all. What is the another name for these bodies, which are guitar shaped bodies? Tell me guys, these guitar shaped bodies. This was the question asked in the NEET PG 2024. They give this picture, these guitar shaped bodies. These guitar shaped bodies, what is the name? They are called as ferruginous bodies. They are called as ferruginous bodies. And if any histopathological type of image is given in pneumoconiosis, suspect what? Sir, it's usually what? It is asbestosis, asbestos bodies. Is that clear? Now I've mentioned that it's the only pneumoconiosis which is associated with malignancy. Now what is the malignancy? If we talk about most common malignancy, again most common malignancy, then it's going to be adenocarcinoma of lung. It is going to be adenocarcinoma of lung. Okay, and if it is the most specific cancer, then that is the mesothelioma. Then it's the mesothelioma. Remember that. Okay, plural mesothelioma. Now if a question will also mention in a different way that there was a weight loss seen and there is a mass in the lungs, if mass is mentioned and there is a weight loss, cancer like features, suspect of what? Asbestosis, mesothelioma. Okay, or they can also mention that what is the marker of mesothelioma? Yes, it is calretinine positive or high calretinine levels. Okay, the marker of mesothelioma is calretinine. Marker. Okay, so that is all about the asbestosis. It is all about the asbestosis. Tell me bache, what is bisonosis? Bisonosis, usually sir, the dust is cotton dust. The dust is cotton dust, and it is usually seen with, okay, which industry bache? Sir, textile industry. Textile industry. Patient usually presents with chest tightness. Monday chest tightness, we call it chest tightness. Okay, that is about the bisonosis. So silicosis, silica dust, asbestos dust, asbestosis. Okay, and the bisonosis is a cotton dust. Bisonosis with the cotton dust. Is that clear? Is that clear to everyone? Textile industry. Chale. Next, anthracosis. Anthracosis, the dust is coal dust. The dust is coal dust. Number first thing. Number second thing is the patient is having massive fibrosis. Can write just. And this fibrosis will be still there. Okay, it will still go on if the patient is even removed from the exposure. Okay, even if the patient is removed from the exposure, the progressive fibrosis will carry on. And if a patient is having rheumatoid arthritis, okay, if a patient is having rheumatoid arthritis, okay, plus a patient is having an anthracosis, this is called as rheumatonemoconiosis, or there is a classical syndrome, क्या बोलते हैं syndrome को? Sir, it is called as Kaplan syndrome. So it is called as Kaplan syndrome. And Kaplan syndrome को also क्या बोलते हैं? When the rheumatoid arthritis, anti-CCP antibodies, yes, plus there is anthracosis, okay, it is also called as rheumatonemoconiosis. It's also called as rheumatonemoconiosis. Is that clear? Yes. Now this anthracosis, okay, it is also called as anthracotic lung. It's also called as black lung when due to these carbon particles get accumulated, okay, it gives an appearance called as black lung, ठीक है ना, due to the carbon particles. Number one thing. Number second thing is guys, when we talk about the intracellular pigmentations, okay, like you have lipofuscin, all right, all the pigments that we have studied in the pathology, you have studied in the pathology, that which of the following is the most common exogenous, all are the endogenous pigments, which of the following is an exogenous most common? Your answer goes to anthracotic pigment, black lung, okay, which is due to the accumulation of the carbon particles. Okay. Now next is going to be bagger sauces. For the bagger sauces, they will usually mention the question on the cardboard industry, and the dust is going to be sugar cane dust. So the dust over there is sugarcane dust. Okay, the fungus that is associated, is thermoactinomycetes saccharine. And one more thing guys, the prevention is 2% propionic acid. For the prevention, goes 2% propionic acid. That is bagger sauces, usually with the cardboard industry, bagger sauces. Then we have farmer's lung or moldy hay. Okay, farmer's lung or moldy hay, the dust is the grain husk. The dust is grain husk. Can you tell me the agent? The dust is grain husk. Okay, if we talk about the agent, it's Mycopolyspora fani. Mycopolyspora fani. Okay, and prevention is 1% mineral oil, and prevention it's 1% mineral oil. Very good guys, it's all about the pneumoconiosis. It was all about the pneumoconiosis. Clear? Okay, it's all about the pneumoconiosis. So let's have a quick recall of all these pneumoconiosis. Okay, what are the pneumoconiosis? These are the respiratory diseases which occur due to the exposure to dust. Okay, due to the exposure to the dust. Okay, now this size of the particles was also asked. Now silicosis is going to be the most common one. Okay, silica dust, bauxite minor, stone dust, and this is question as well, follow up for the tuberculosis. Number one. Number second, the only pneumoconiosis which will be associated with the malignancy is going to be asbestosis, and asbestosis may you already know that the most common is adenocarcinoma of the lung, and the most specific is the mesothelioma. Mesothelioma, you know that calretinine marker is there, and in mesothelioma we have classical bodies. What are the bodies called in mesothelioma? So they are called as psm-i bodies. They are called as psm-i bodies, and these psm-i bodies are also seen with papillary thyroid cancer. Okay, papillary thyroid cancer. They are also seen with meningioma. They are also seen with the serous cyst adenoma. Okay, they are also seen with papillary thyroid cancer. These are all the conditions where we can see these psm-i bodies. Usually they have what? Calcium. There is increased calcium in the psm-i bodies. ठीक है ना, ये बात याद रखना. Mesothelioma, we have psm-i bodies. Okay, so all the images that they can ask: eggshell calcification, snowstorm appearance, ferruginous bodies has been the question asked. Okay, this has been psm-i bodies multiple times. Okay, with respect to other features like meningioma, okay, thyroid cancer or ovarian tumor. Okay, yes, PSM is a mnemonic. Very good. Then popcorn calcification is going to be pulmonary hematoma. Please do remember the anthracosis, Kaplan syndrome, rheumatoid arthritis plus anthracosis, which is also called as rheumatonemoconiosis. Clear? Now let's move to the next topic. Okay, a patient with the 3 hypopigmented anesthetic pads with no nerve involvement. This is the update April 2025. There is no nerve involvement present to your OPD. What shall be your treatment approach? Okay, now it as a case of a hypoanesthetic pads, it's a case of a leprosy. Okay, usually we classify based upon the lesions and the nerve involvement, but with the recent update, if there is no nerve involvement, okay, if there is no nerve involvement with 1 to 5 hypoanesthetic pads, it is a case of a which type of leprosy? So it is a case of a paucibacillary leprosy. So it's a case of a paucibacillary leprosy. Okay, chale. Now you already know, my dear students, that leprosy having 3 drugs in the treatment regime. Okay, now what are the 3 drugs? We have dapsone, rifampicin and clofazimine. Okay, now you know that for paucibacillary, what is the duration of the treatment? Tell me in the comment section, everyone. For paucibacillary, what is treatment? What is the duration of the treatment? For pauci, what will be the duration for the treatment? Yes, for pauci, what is the duration of the treatment? It's for 6 months. Okay, what will be the duration? That is 3 multi-drug therapy regime for how many months? For 6 months. For 6 months. Okay, so remember, now let's define what are the classical differences between the paucibacillary and the multibacillary. Okay, the number of skin lesions 1 to 5 in pauci, and in multi the lesions are more than 5. The lesions are more than 5. Now if we talk about the 3 drugs that are given, the first drug, remember, it's rifampicin, the oldest drug for the leprosy. Okay, and then followed by that we have dapsone, followed by that we have clofazimine. Okay, and then multibacillary, what are the 3 drugs? We have rifampicin. Okay, we have dapsone and we have clofazimine. Thank you, Dr. Omkar. Chale. Same goes to from my side as well. Okay, chale, rifampicin, dapsone and clofazimine. We have 3 drugs, rifampicin, dapsone and clofazimine, and depending upon the duration of the treatment, for how long you will give? 6 months for paucibacillary, and for 12 months you go for multibacillary leprosy. Number first thing. Number second thing is add one more column about the nerve involvement. Add one more column about the nerve involvement. Okay, now if we talk about the nerve involvement, there are 0 nerves, none, no nerve involvement in case of a paucibacillary, and in case of a multi, more than 1 or 1. Okay, more than 1 or 1. About the follow-up norms, they are same only, yearly for 2 years, and then for the multibacillary you have for 12 months. Yearly for 5 years. So that's all about the types of leprosy. Okay, now one more important thing that you have to remember for the leprosy is the lepra reaction, that the question has been asked, type 1 and type 2 lepra reaction, which you easily know with the help of rule of 5. Okay, there are 2 types of lepra reaction, type 1 lepra reaction and type 2 lepra reaction. Okay, so what is the question that they will ask on the lepra reaction? Okay, they will ask about the hypersensitivity reactions. So rule of 5, what you will add to type 1, it will become 5. What you will add on 1, it will become 5. So hypersensitivity 4, type 4 hypersensitivity reaction, and type 2 lepra reaction is associated with type 3 hypersensitivity reaction. Okay, this is called as rule of 5. ठीक है. Now sir, for the lepra reaction, what is the drug? We usually use the thalidomide. We usually use also thalidomide, but if they ask a drug of choice for lepra reaction, your answer is going to be steroids. Your answer is going to be steroids. Thalidomide we also use, but classical drug is going to be the steroids. Clear? Classical drug is going to be steroids. Clear to everyone? Clear to everyone? Yes. Types of leprosy. Chale. Done. Okay. Now what is the nerve usually involved, bache? What is the nerve usually involved? So usually the nerve involved is ulnar nerve, but if they ask which cranial nerve is involved, if they ask which cranial nerve is involved, then the answer goes to facial nerve. Then the answer is facial nerve. Okay, that's all about the leprosy. That's all about the leprosy. Is that clear? Is that clear to everyone? Yes, the most common nerve involved is the ulnar nerve, but if they ask cranial nerve involved, then the answer goes to the facial nerve. Everything clear so far? Yes. Anyone any doubts? Yes. Chale. Then this lotus over here. Okay, this is a logo for National Leprosy Elimination Program, NLEP. Okay, this sapna was a question asked in your NEET PG and FMG as well. The leprosy campaign mascot, sapna. Okay, and this is a logo for National Tuberculosis Elimination Program. Okay, first the goal was by 2025. Okay, but as per WHO, now it is 2035. Okay, as per SDG, Sustainable Goal Development, they by 2030 will eliminate tuberculosis by this year. Okay, what is elimination? Breaking the chain of transmission. What is eradication? You completely remove the disease, even along with the causative agent. Okay, causative agent as well. Clear to everyone? Yes. Is that clear to everyone? Chale. Next, we move to the next question. From the National Vector-Borne Disease, the ASHA worker during her house visit in a village of Bihar. So ASHA is the one who is going for the active surveillance of this disease. So what is active surveillance? When a health worker is going to the home, house by house, in order to check the disease or go for the investigations. Okay, so ASHA worker during her house visit in a village of Bihar, she came across a patient complaining of fever, weight loss for 3 months. Along with that, I will add one more feature. So patient also had hepatomegaly, so it will be easy for you to diagnose. So hepatomegaly was also there. Okay, and she noticed that the skin was dark and the abdomen was distended. That's why hepatomegaly, abdomen distended, hepatomegaly was there. She performed a test. What is the name of the test? So she performed a test, RK39 dipstick test on urine, which turned to be positive. What is your probable diagnosis? Which turned to be positive? What is your probable diagnosis? So you already know that ASHA, active surveillance, hepatomegaly, fever, weight loss, RK39 dipstick test. So many hints that it's a case of a leishmaniasis. Sir, it's a case of a leishmaniasis, also called as Kala Azar. Now let's discuss about the leishmaniasis. So first of all, this is usually seen in UP, Bihar, West Bengal. Okay, and if we talk about the agents, we have L-donovani. Which will cause visceral leishmaniasis. Causing visceral leishmaniasis, जिसको क्या बोलते हैं? काला अजर. Okay, followed by that we have L. tropica, which will cause the cutaneous leishmaniasis. Okay, followed by that we have L. brazilians, which will cause mucocutaneous leishmaniasis. Which will cause mucocutaneous leishmaniasis. Okay. Now, my dear students, if we talk about the vector of leishmaniasis, it is sandfly और क्या बोलते हैं phlebotomous fly. This phlebotomous fly was the question asked PYQ. Okay, and the reservoir is wild animals. As wild animals. Okay, for the diagnosis, you already know that we have intracytoplasmic inclusion bodies called as LD bodies. Number first. Number second, we also go for the test called as RK39 dipstick test. Okay, RK39 dipstick test. So what exactly will this test do? We'll check the antibody in the urine and blood. We also have one more test called as leishmania test, which will tell me about the immune status of the patient. It is not the diagnostic test. It is not the diagnostic test. So what are the tests? What are the tests we have for the diagnosis? What are the tests we go for? We go to check the LD bodies. LD bodies क्या होती है? Leishmania, Donovan bodies. Okay, and these are the intracytoplasmic inclusion bodies. Okay, and this is a confirmatory test as well. We have one more, sir, called as RK39 dipstick test. We have RK39 dipstick test, which will check the antibody in urine and blood. So write it down, RK39 dipstick test. There is antibody detection in urine and blood. There is antibody detection in urine and blood. Clear, guys? Yes. And it's an initial test. The initial test that we do for the diagnosis is RK39 dipstick test. Remember, hepatomegaly भी दिखती है. चले आगे बढ़ते हैं. Now, what exactly is the drug of choice? You already know this. This is the same drug that we use in cryptococcal meningitis. This is the same drug that we use for the mucormycosis. It's L-amphotericin B. It's L-amphotericin B. Okay, and vector disease, vector control के लिए we use dichloro-diphenyl trichloroethane insecticide. Okay, and do remember that second drug of choice that is for the leishmaniasis is called as miltefosine, and miltefosine is a drug of choice for post-Kala Azar dermal leishmaniasis. I'm writing here in case you come across through this drug as well, miltefosine. Okay, drug of choice for post-Kala Azar dermal leishmaniasis, PKDL, that is post-Kala Azar dermal leishmaniasis. That is all about the leishmaniasis question, important. Okay, one more thing, tenaces, guys. Let me tell you about the tenaces here only, that Tinea solium and Tinea saginata for the tenaces. And drug of choice for tenaces is, then it can cause neurocystic, that Tinea solium and Tinea saginata can cause also neurocystic cirrhosis as well. Okay, starry sky appearance. Drug for the neurocystic cirrhosis is going to be albendazole along with the steroids you will give. Okay, and for the tenaces we use a praziquantel and the niclosamide. For the tenaces we use praziquantel and niclosamide. Remember, praziquantel and niclosamide. For neurocystic cirrhosis, starry sky appearance, Tinea solium, Tinea saginata, beef and pork, we use albendazole and steroids. Okay, so do remember this, and it's not included in the National Vector-Borne Disease Program. Okay, filariasis is there, leishmaniasis is there, malaria is there, dengue is there, chikungunya is there. Okay, but not these three. Okay, now talking about the filariasis, guys, again so many questions asked upon the filariasis. Okay, now remember the agent for filariasis. What is the agent for filariasis? It is Wucheria Bancrofti. It is Wucheria bancrofti, and sir, it's Brugia malai. It is Brugia malai. So the question was asked about the Brugia malai and Wucheria bancrofti. The question was asked in NEET PG, which among the following will not have the nucleus present at the tip of tail? Okay, remember, in case of Wucheria bancrofti, sir, no nucleus. Sir, in case of Brugia malai, so there are two nucleus. There are two nucleus, terminal and subterminal nucleus present at the tail. Okay, if there is no nucleus, that is Wucheria bancrofti. Okay, now remember that the clinical features usually what will be there. Number first thing is there can be lymphedema, can be hydrocele, and dermatolymphangiotes ना, elephantiasis बोलते हैं इसको. और these are the clinical features over there. And what will be the treatment? For the treatment we usually give three drugs. Okay, we say that it will be eliminated by 2027. Okay, and for the elimination also we use the three drugs: albendazole, we use ivermectin, and we have diethylcarbamazine. We also do the provocative test after administering a drug, DEC. Okay, so for the diagnosis as well, but to make sure that 100 mg oral DEC is given, and then after 1 hour we take the peripheral blood smear test. Okay, after 1 hour we go for the PBS. So eliminate, what is the goal for elimination? Goal is by 2027 for the filariasis. Is that clear? So that was all about the filariasis. We have one more test for the filariasis called as membrane filtration test. Sir, we have one more test for filariasis called as membrane filtration test. Treatment, if one drug you have to choose DEC, but for the elimination there's a triple therapy. And do remember that we usually take a one peripheral thick smear at night. At what time? It's usually taken at night time. Okay, the most common sensitive method is a membrane filtration test. Okay, membrane filtration test. That is all about the filariasis. Okay, so one drug for a treatment, if you have to choose DEC. We usually give how many doses? 12 doses, 6 mg. And but if you have a triple drug therapy for the elimination of this disease, then your answer should be albendazole, ivermectin, and diethylcarbamazine. So you remember this with the mnemonic AID. Clear to everyone? Is this much clear to everyone? Yes. Can we move to the next part? Okay, guys. Chalo, leishmaniasis, clear? RK39 dipstick test, L-amphotericin B, miltefosine. Here, do remember the agents. Agent is Wucheria bancrofti and Brugia malai. If there are two nucleus, that is going to be Brugia malai. If there is no nucleus, the answer goes to the filariasis. Clear, bache? Yes. Chalo. Now the next part will start just after the break. Okay, we'll take a 10 minutes of break. We'll have a 10 minutes of break and then we start. Okay, sure. So let's begin, guys. I'm audible now and visible to all of you. Please let me know. I'm audible now and visible to all of you. Please let me know. So let's start with the food adulteration disease. Okay. You guys can tell your friends to join back. 10 minutes are over. Let's start with a food adulteration diseases. Okay. Let's. Yes, sir. Okay, all clear so far? Whatever, all the topics that we have discussed so far: vitamins, leprosy, pneumoconiosis, indicators of quality life, and case control study, anemia Mukt Bharat. Everything is cleared? Everything is clear, guys? Yes? And about the PDF, don't worry, guys. I'll be sharing the PDF. I've already shared about OB-GYN part 1 and part 2 in the MeduHub channel. I'll share this PDF as well. Try to be more interactive, okay? I'm already writing for you guys, so this time it is more better to focus on the recall. Okay, whatever you have studied in these months, try to recall that information. Okay, chale. So everyone is back, so let's begin. With a food adulteration. Okay, now some foods we'll discuss, and we have the toxins associated, okay, and the classical features. Okay, now let's start with the first question. In a village, a young man with a history of successive crop failure develops a progressive spastic paraparesis with the upper motor neuron signs and gait instability. Okay, with upper motor neuron sign and gait instability. Okay, the most likely toxin responsible for this condition is, now which crop is associated, what is the toxin associated, and what are the clinical features. Okay, now my dear students, if we talk about the food adulteration disease, let's discuss first and then get back to the question. Okay, now if we talk about the first disease, that is letharism. Okay, now the toxin in the letharism is BOVA. What is the toxin? Sir, it is BOVA. What is BOVA? It's beta oxalyl aminoalanine. It's beta oxalyl aminoalanine. Okay, now this beta oxaloaminoalanine, they have asked us in PYQs as well. Sometimes rather mentioning the full form, rather mentioning the short form, they can mention beta oxaloaminoalanine. So that's BOVA. Okay, now remember, guys, if we talk about the agent associated, it is kesari dal, and the food stuff is yellow pulse. And the food stuff is yellow pulse. Okay, if I talk about the second one, epidemic dropsy, the toxin associated is sanguine. The toxin associated is sanguine. Okay, and the agent is ardumone seed. The agent is ardumone seed. Okay, and the food stuff is mustard. And the food stuff is mustard. This was a question asked with the clinical features of a bilateral pedal edema, diarrhea, and cardiac failure. Okay, I will be discussing all the clinical features of all this disease. Third one is endemic ascites, in which the toxin is pyrrolizidine. What is the toxin associated? The toxin is pyrrolizidine. Okay, and the agent is corotorilla seed. And the food stuff is millet. And the food stuff is millet. Okay, if we talk about aflatoxicosis, the toxin associated is aflatoxin. The toxin associated is aflatoxin. Okay, the agent associated is Aspergillus flavus. and the foodstuff is groundnut. Again the PYQ multiple times related to the hepatocellular carcinoma. Okay, followed by that we have ergotism. Okay, the toxin is ergot alkaloid. The toxin is ergot alkaloid. Okay, the agent is claviceps fusiform. The agent is claviceps fusiform, and the foodstuff is flowering plants. And the foodstuff is flowering plants. Okay, now the question that they can ask from this particular topic is, they will give the clinical features. They will not directly ask the question, rather than that they will give the clinical features, which is already given in a question given with upper motor neuron signs and the gait instability. Okay, and these are the classical features of a letharism, and for the toxin which is related to the letharism is beta oxaloalanine. The toxin associated is beta oxaloalanine. So what are the clinical features of the food adulteration disease? The first one, if we talk about the letharism, patient is having neuroparalysis. Patient is having neuroparalysis and osteoparalysis. Patient is having neuroparalysis and osteoparalysis. Okay, and this is a classical feature of osteoparalysis, gait instability. Okay, and the question was given, what is the toxin? You already know, so the toxin is BOA. The toxin is BOA. Okay, the second one is epidemic dropsy. Okay, if I talk about epidemic dropsy, what are the features? Patient is having bilateral swelling of legs, or edema will be given. Followed by that, patient will have cardiac failure, and diarrhea. This is the PYQ that has been asked in your exams. Epidemic dropsy, and the toxin which is associated with this epidemic dropsy, your answer goes to sanguine. Your answer goes to sanguine. Okay, followed by that, endemic ascites, already given in a question that ascites like features. So what are the two main symptoms? They will mention increased liver enzymes, bilirubin, and that's jaundice and ascites. So ascites and jaundice are the classical features of which food adulteration, guys? That is endemic ascites. Okay, then followed by that we have an aflatoxicosis. Remember aflatoxicosis, they will usually mention that prone to hepatocellular carcinoma, HCC. So hepatocellular carcinoma is going to be associated with the aflatoxicosis, aflatoxin. And the last one is ergotism. This will have a features of gangrene. There will be a vasospasm, gangrene, and the toxin associated with ergotism is ergot alkaloid. The toxin associated is ergot alkaloid. Is that clear to everyone? Yes, clear to everyone. Now sir, how exactly we can prevent and control these food adulteration diseases? First of all, so we have to remove the toxin. So there should be removal of toxin. Okay, what are the methods by which we can remove the toxins? By steeping method or parboiling. By steeping and parboiling. Okay, followed by that we should start vitamin C prophylaxis. We should start vitamin C prophylaxis, or ban the crop. Ban the crop. Okay, and educate and aware people about the consequences of consuming the crop, about the disease. So this is all about the clinical features of food adulteration disease. So remember guys, if we talk about the first one, that is letharism, remember the toxin is BOA. Okay, patient is having a neuroparalysis or the osteoparalysis. They can give this picture. Okay, It is BOA, and the answer is okay. Followed by that, epidemic dropsy, bilateral swelling of the legs, cardiac failure, and diarrhea. Followed by that, the toxin is sanguine. Followed by that, endemic ascites, patient is having ascites over there, as well as jaundice, aflatoxicosis, hepatocellular carcinoma, and ergotism. We have ergot alkaloid. We have ergot alkaloid. Clear to everyone? Yes. Then how to prevent and control removal of the toxin by steeping or the parboiling method. Okay, removal of the toxins by steeping and parboiling method. The vitamin C prophylaxis, you ban the crop or educate and aware people about the disease. Okay, now let's move to the next question. One of the methods of health communication where 4 to 8 persons are qualified to talk about the topic and discuss a given problem. But once we discuss this problem, it should be in a sequence. There should be a particular order. There should be a order in the speech or sequence in the speech. The method is called as. So we have methods of communication, Socratic and didactic. We have studied in our main sessions as well. Okay. Now, if 4 to 8 persons are qualified, which are talking about a topic, okay, on a given scenario, and all these are discussing this in a particular manner, there is an order: first person, second person, third person. Okay, so when there is a sequence, S is for sequence, S is for symposium, so we call it as symposium. Okay, now for example, if the question will be given that a large group of audience in not a sequence, there is no sequence. If there is no sequence, usually you see in the news channels that everybody is speaking. Person 1 will skip out of nowhere, person 5 will come, then person 3 will come. So when there is no correct order of speech, that is called as panel discussion. Agar sequence hai, S is for sequence, S is for symposium. Clear guys? Agar P hai, panel discussion, to pagalon ki tarah. You might have seen in the news channels when they discuss about some maths, some about some national issues. Okay, they usually, there is no correct order of speech. Okay, now let's discuss about the particular methods of communication. First one, we have a focus group discussion. Okay, we have a focus group discussion. Write it down. There is a discussion among 6 to 12 persons. There is a discussion among 6 to 12 persons. There is one group leader, and one recorder. Next one is panel discussion. Next one is panel discussion. So panel discussion, I've already said that there will be discussion among 4 to 8 experts. There's discussion among 4 to 8 experts with no specific order of speech. With no specific order of speech or sequence, right? No sequence. Or no sequence. Followed by that, right? The classical example is news channel. Example is news channel. Then we have symposium. So what is symposium? Okay, there is discussion among 4 to 8 experts. Okay, followed by that, there is a correct order of speech. There is a specific order of speech. Or sequence. Okay, there is no discussion in between, that they will only deliver. There is no discussion in between the experts, they will just come and deliver. But in case of her, there is discussion in between the experts as well. So no discussion among experts, no discussion among experts. It's just they will deliver. They will deliver. Clear? Okay, so if there is a correct order of speech, you go answer within symposium. If not, panel discussion. What is demonstration? The active principle for demonstration is seeing is believing. Learning by doing. Seeing is believing, learning by doing. Okay, and example we have ORS. Example we have ORS. Okay, one more technique is called as a spikes technique or P spikes. It's a protocol of 6 steps. Okay, where we invite, then explain, then give a knowledge about the particular disease, and then we take care of emotions as well, and in the end we summarize the disease. Okay, and anytime when we have to break the bad news, for example, if a young guy is suffering from a blood cancer and we need to tell this to our family, so in order to break this news we use a technique called as spikes technique. It's not like directly you go and tell them your son is having a stage 4 cancer and he's going to die. No, you have to summarize it, you have to explain it, you need to give them a knowledge a bit, you need to take care of emotions as well. So this approach, by this approach to the attendants in order to break the bad news, it's called as spikes technique. Simple question was asked, in order to break the bad news, what is the technique, what's the method of communication? In order to break the bad news, we have a technique called as spikes technique, So which method of communication is the best? Okay, which method of communication is the best? That is going to be IPC. IPC is the best one. What is IPC? Interpersonal communication. That is interpersonal communication. We have, for the contraception counseling, we have an approach called as gather approach. Called as gather approach. Okay, what is gather approach? It's also called as cafeteria approach. Greet, ask, tell, help, explain, return. That is gather approach, also called as cafeteria approach, and it is for the contraceptive counseling. Contraception counseling. Clear? Chalo guys. Okay, so that was all a concise topic for the communication. Okay, let's move to the next one. The best parameter. Okay, so remember guys, if a correct order of speech, that is symposium, not a correct order of speech, that is panel discussion. Workshop में series of these methods in which we impart the practical skills. ठीक है ना? चलो. The best parameter for the assessment of acute nutrition. Now this question has been asked multiple times. Important. All these questions that I'm discussing are important. Now let's discuss weight for age, weight for height, height for age with a simple mnemonic as well. Okay. So whenever we are discussing about weight for age, okay, so weight for age, you already know it's for acute plus chronic. Weight for it, you know, acute plus chronic under nutrition. Okay, when we talk about a weight for height, so you will remember, sir, decrease weight for height, WHA. Height for age, you will remember HAC, HAC. So how do you remember WHA? W is the weight, H is height, and weight for height, A is acute malnutrition. So weight for height, you remember with acute malnutrition. We remember with acute malnutrition. Clear? And it is also called as, क्या बोलते हैं इसको? It started with W only, so it is also called as wasting. also called as wasting. Okay. Second, it's HAC, hack. What is HAC? It is chronic malnutrition. So H is height, A is age, and C is chronic malnutrition. So HAC, you remember with chronic malnutrition. Okay, which is also called stunting. Also called stunting. So weight for height, remember, weight for height and height for age. Weight for height and height for age. Clear? So stunting and wasting. Stunting and wasting. Okay. Now we have two types of malnutrition. Okay. That is Kwashiorkor and marasmus. That is Kwashiorkor and marasmus. Okay. Now, based upon the given clinical question first, based upon a given MCQ, acute malnutrition, the best parameter is, I've already discussed, WHA, W-H-A. Okay, so you will remember W-H-A. So weight for height is acute malnutrition. Is that clear? Is that clear, Vacho? WHA is clear? Everyone, WHA is clear? Yes, sir. Chale bachcho. Nice. Now, if we compare Kwashiorkor and marasmus, okay, Kwashiorkor will develop into the children which are deficient of proteins only. But in case of marasmus, they are deficient of proteins and calories. Okay, it occurs in the age group between 6 months to 3 years. Okay, while as the marasmus, it's common in infants and under 1 year of age. Under 1 year of age, the subcutaneous fat is preserved, due to which the ribs are not very prominent. Due to which the ribs are not very prominent. But here, the subcutaneous fat is not preserved. Ribs become very prominent. Okay, edema is present in case of, you can see, edema is present in case of an Kwashiorkor, while as in case of an marasmus, edema is absent. In case of a marasmus, edema is absent. Followed by that, if we talk about the fatty liver, hepatomegaly is seen. Hepatomegaly is seen with Kwashiorkor, while as there is no hepatomegaly, there is no fatty liver. Okay, there is no fatty liver associated with marasmus. Lethargic baby, here it's alert and irritable. The muscle wasting is mild or absent. Here the muscle wasting is more in case of marasmus. That is why marasmus में क्या बोलते हैं, मरा हुआ बच्चा. Okay. Then the person suffering from Kwashiorkor needs adequate amounts of protein, but in case of marasmus, it needs protein, fats, carbs, everything. Okay. Poor appetite, here it's voracious feeder. That is all about the comparison between the Kwashiorkor and marasmus. In marasmus, we have old man face. Okay, in Kwashiorkor, it's a moon face. Moon face. There is a one more sign in the hair seen with the Kwashiorkor patient. What is the sign? What is the sign called as? So the sign called as Kwashiorkor में होती है flag sign. कहाँ पे होती है? Black white hair. Okay, and it's seen with the Kwashiorkor patients. It's seen with the Kwashiorkor patients. Clear to everyone? Yes. So remember, guys, if prominent reps, okay, more muscle wasting with the old man face, with the subcutaneous fat not preserved, okay, with a severe muscle wasting, the answer is going to be marasmus. The answer is going to be marasmus. Okay, and opposite to that, it's gonna be Kwashiorkor. Clear to everyone? Yes. Let's move to the next part. Okay, Kwashiorkor marasmus is done. Which of the following is the least common complication of measles? Which of the following is the least common complication of measles? Okay, now let's discuss measles. You already know that measles is also called as rubeola. Measles is also called as rubeola. Okay, the agent for measles is RNA paramyxovirus. What is the agent? Sir, agent is RNA paramyxovirus. The agent is RNA paramyxovirus. Okay, the incubation period is 10 to 14 days. The incubation period is 10 to 14 days. So remember, with the measles 45, that is period of communicability. Period of communicability is the 4 days before the rash and 5 days after the rash. It is 4 days before the rash and 5 days after the rash. The 3 C's which are classically seen in the patient of measles is cough, coryza and conjunctivitis. We have cough, coryza and conjunctivitis. Okay, now bluish spot on the red base of buccal mucosa, which is opposite to the second molar teeth. These spots are called as, yes, these spots are called as Koplik spots. These spots are called as Koplik spots. Okay, and we have a hyperpigmented line on the conjunctiva. This line is called as Stimson's line. क्या बोलेंगे बच्चे इसको? So the line is called as Stimson's line. Okay, now the common complications which are associated with the patients of measles. First of all, the most common complication is going to be otitis media. Patient also have diarrhea, pneumonia as a complication, but the most common, if they ask, the most common complication if asked about the measles, that's going to be otitis media. That's going to be otitis media. What are the other complications? Patient can have diarrhea. Patient can have pneumonia as well. Patient can have pneumonia as well. If asked rare complication, that is subsclerosing panencephalitis. SSPE. Okay, so that's the same question that I asked. What is the most least common complication? Your answer is going to be SSPE, subsclerosing panencephalitis. Okay, now followed by that, the vitamin deficiency, if asked, the vitamin deficiency associated with the measles, it's vitamin A. Vitamin A. The name of the vaccine strain is Edmonstron Zagreb. Edmonstron Zagreb. Okay, the treatment is supportive. That we have a measles elimination strategy: catch up, keep up and follow up. Catch up, keep up and follow up. Okay, one more question, guys. What is the name of the giant cell? What is the name of a giant cell in measles? What is the name of the giant cell in measles? The name of the giant cell in measles is Warthin giant cell. Okay, so that is all about the measles. Okay, and the measles vaccine is given at how many months? So it is given all around 9 months. It's given around 9 months. Okay, and tell me, what is the diluent of a vaccine? Measles vaccine diluent is, remember, that is going to be sterile water. Yes, that's going to be very good. Sort of Warthin giant cell, and the vaccine strain is Edmonstron Zagreb, given by 9 months, and the diluent of this vaccine measles is sterile water. Chale. Next question. Under ESI Act, the sickness benefit is given for a period of, now as per the ESI Act, Employee State Insurance Act, that the sickness benefit will be given for how many days? It's 3 months, 91 days. It's 3 months, 91 days. Now let's discuss about this act. ESI Act, Employees State Insurance Act, it include all the industries and areas. Okay, so if they ask which of the following is not included, so write down except except is railway and mining. Except is railway, except is mining and defense. And defense. Okay, now as per this act, the facilities that they have is IPD plus OPD for worker and family. IPD plus OPD. Okay, if we talk about the sick leave, okay, the sick leave they usually given for 91 days. So it's given for 91 days. And if they ask what is the percentage of the salary they will be giving in 91 days, 70% of salary. 70% of salary. Okay, if it's mentioned that extended sickness leave, that is given for 2 years. That is given for 2 years. And what is the salary given? 80% of salary. 80% of salary. Okay, if question is maternity leave, it's given for 6 months. Enhanced leave vasectomy for 7 days. Tubectomy mode, that is 14 days. Okay, if you talk about the disability benefit, temporary, they'll give leave till recovery. And if we talk about permanent benefits, they'll give pension as per the guidelines. They'll give pension as per the guidelines. Okay, yes, 26 weeks, that's 6 months. Funeral benefits, rupees 15,000 for funeral benefits. Rupees 50,000 for funeral benefits. Salary in 6 months, 100% salary. They'll give 100% salary in 6 months. Okay, now contribution of total is 4%, employee and employer. Okay, it's 0.25% of wage and 0.75 and 3.25. It is 0.75 and 3.25 of wage. That is about ESIC. That's about ESIC and the facilities. Clear? Is that clear to everyone? Yes? Chalo. Now, let's move to the next question. We have already discussed this question, I guess. ASHA worker coming across a 40-year-old male with a history of fever with chills and cachectic look during a house-to-house survey. So ASHA is going for house-to-house survey, active surveillance on suspicion of a disease which is caused by sand fly. So disease is caused by sand fly and it's included in the National Vector-Borne Disease Program. What is the test it will perform? We just studied, guys. What is the test that she will perform? What is the test that she can perform? What will be your answer? So the test that she can perform is RK39 depth stick test. It's RK39 depth stick test. Okay, so if I talk about this first test, it's peripheral thick smear at one peripheral thick smear in the night time. One peripheral thick smear at the night time. What will be your answer, guys? So it's usually done for filariasis. It is done for filariasis. Now tell me, my dear students, that peripheral thick and thin smear, the multi-purpose worker male at PHC will take 2 smears. One is thin and one is thick. It is done for which type of disease? Okay, and again I will tell you, this disease is also included in National Vector-Borne Disease Program. Okay, so thin will tell me about the species and thick will confirm the disease. So what is the name of the condition in which we take 2 peripheral thick and thin smear? That is going to be malaria. Very good, that is malaria. So we also do rapid diagnostic test which contains and which detects an antibody. Okay, क्या कौन सा टेस्ट करते हैं? We go for LDH and histidine rich protein. LDH and histidine rich protein. Okay, RK39 dipstick test, you already know what is the diagnosis of this condition. It is leishmaniasis. It is going to be leishmaniasis. Okay, then sputum tuberculosis. Clear? So it is RK39 dipstick test. Next question from the sexually transmitted disease. 50-year male present with a medical emergency with the complaints of fever, headache, and on examination neck rigidity is seen. So classical tried, which is of a meningitis. The investigation confirms a case of HIV with the cryptococcal meningitis. So what should be the possible CD4 count? What should be the possible CD4 count so that at which this opportunistic infection will take place? Now you already know the classical tried, fever, headache, and neck rigidity. It is, or neck stiffness. It is a case of a meningitis. And mentioned in the question, this is the case of an HIV. You already know that once a patient is having HIV, patient is immunocompromised, and when the patient is immunocompromised, the infections during that state are called as opportunistic infections. If we talk about the opportunistic infections in HIV, it depends upon the CD4 count. If we talk about the most common opportunistic infection in case of an HIV, it's in India, it's going to be tuberculosis. But if all over the world, it's going to be pneumocystic jirovecii pneumonia. Okay. Now we have already discussed that at what CD4 count the cryptococcal meningitis will take place. Write down in the comment section. The answer is going to be option C, between 200 to 100. Between 200 to 100. Now, sir, if I talk about most common opportunistic infection, most common opportunistic infection, your answer goes to tuberculosis. Usually we'll mention in India only. Okay, the question will ask with respect to India. Okay, most common opportunistic infection is TB. Okay, now the CD4 count at which these infections will take place, we'll learn. So if a CD4 count is more than 500, what is an opportunistic infection? No opportunistic infection will take place. Okay, if the CD4 count is between 500 to 200, the opportunistic infection a patient can have is TB, it is candidiasis, and we have a malignancy called as Kaposi sarcoma. Okay, so if the patient is having a CD4 count between 500 to 200, so the opportunistic infections, we have tuberculosis, we have candidiasis, and we have Kaposi sarcoma. If the CD4 count is between 200 to 100, the classical opportunistic infections we can have is pneumocystis, pneumocystic jirovecii pneumonia, and cryptococcal meningitis Okay, followed by that, if a CD4 count is between 100 to 50, if a CD4 count is between 100 and 50, the opportunistic infections we have, right, toxoplasmosis. We'll write the main ones, toxoplasmosis. And if it is less than 50, so we have CMV, most common we have non-Hodgkin's lymphoma. Is that clear? Is that clear to everyone? Yes. Now followed by that, let's learn this image. This question was asked that a patient of HIV came with the complaints of flutters in eye and the blurring of vision. Upon the fundoscopy, there was a classical spots. What are the spots called as? Sir, we have cotton wool spots. And the appearance called as by appearance. So fundoscopic features of cotton wool spots and psm-i appearance. This is a classical case of CMV retinitis. This is CMV retinitis. And the question was asked, what is the drug of choice for CMV retinitis? Your answer should be, what is the answer, sir? Ganciclovir. Okay, it's Ganciclovir. Is that clear? Remember, don't mark acyclovir answer for the, don't mark acyclovir as answer for the, don't mark acyclovir as answer for the CMV retinitis. So what is the answer for CMV retinitis? So answer for CMV retinitis is Ganciclovir. Okay, so what are the fundoscopic features? We have cotton wool spots and psm-i appearance. Okay, now if you look at this if you look at this MRI, we have multiple eccentric dots. Okay, we have multiple eccentric dots, and these multiple eccentric dots are seen with a patient having cerebral toxoplasmosis. These are seen with the patient having cerebral toxoplasmosis, and cerebral toxoplasmosis or toxoplasmosis is an opportunistic infection seen with a HIV patient when the CD4 count is between 50 to 100. Okay, between 100 to 50 or 50 to 100. Okay, now this toxoplasmosis you already know, caused by Toxoplasma gondii, but main here thing is the clinical features, or how exactly will the patient present. You know that the triad of toxoplasmosis, we have H, C and C. Okay, what is the triad? H, C and C. So H is going to be hydrocephalus, C is chorioretinitis. Okay, and one more C is intracranial calcification. Intracranial calcification. Okay, intracranial calcification. So that's HCC. This is a triad of toxoplasmosis. Okay, now if a question will be asked that what is a drug of choice for toxoplasmosis, so drug of choice for toxoplasmosis, drug of choice for toxoplasmosis is asked. So remember, the drug of choice for toxoplasmosis in pregnancy is pyramycin. If not in pregnancy, we use three drugs. We use pyrimethamine, we give leucovorin and sulfazidine. Is that clear? So pyrimethamine, leucovorin and sulfazidine. Okay, this is an image as also, this is an image of Kaposi sarcoma. This is the image of Kaposi sarcoma. So what is the treatment? Treatment is going to be surgery. Treatment is going to be surgery. Kaposi sarcoma, treatment is going to be surgery. Clear? So what is the classical feature? HCC. So what are the features? Patient will complain of headache, seizures in case of a cerebral toxoplasmosis. In case of a cerebral toxoplasmosis, patient will complain of seizures. Okay, clear to everyone? Yes, so that is all about the opportunistic infection. That is all about the opportunistic infection. Now one more question, guys. Now if a patient is having pneumocystic gyrovascular pneumonia, PJP less than 200 will be the CD4 count. Can you tell me what will be the prophylactic drug or the drug of choice for a PJP? What is a drug of choice? What is the drug of choice? Yes, Sanjam, Saurav, tell me, guys, being you guys are interactive enough. Yes, what? Good, keep answering like this only so that you are recalling. Okay, so tell me what will be the drug of choice. It will be clotrimazole. Okay, it will be clotrimazole. Okay, with what is the stain used? PJP ke liye stain, GMS, Gomori, methamine, silver stain. Okay, for cryptococcal meningitis, what is the drug of choice? You already know. So drug of choice is LAMB, L-amphotericin B, L-amphotericin टेरेसिन बी. इज दैट क्लियर? इज दैट क्लियर? चलो, क्रिप्टोकोकल के लिए एल एम्फोटेरिसिन बी, क्रिप्टोकोकल के लिए एल एम्फोटेरिसिन बी. ओके. पीजेपी क्लोट्रीमोक्सोजोल, टॉक्सोप्लाज्मोसिस, pyrimethamine, leucovorin and sulfacidine, CMV retinitis, Jan, cyclovir. This is all about the opportunistic infection in HIV. If I talk about बच्चों में कौन सा ड्रग स्टार्ट करोगे? 2 drugs, nevirapine and zidovudine. Okay. If mother is on ART, nevirapine only. If not on ART, nevirapine and zidovudine. Okay. Post exposure prophylaxis. Post exposure prophylaxis में what are the drugs you will start? Yes, tenofovir, emtricitabine, dolutegravir. 3 drugs, not a monotherapy. We go TLD. Okay. Tenofovir, emtricitabine, also lamivudine we give. Is that clear? And newborn prophylaxis में nevirapine and zidovudine. Nevirapine and zidovudine. Okay. चलो. What is the single best test for HIV? Single best test. So single best test is going to be Western blot. So single best test is going to be Western blot. Okay. चलो, window period में we'd go for P24 है ना. What is window period? Entry of infection till the detectable antibody present. That is going to be window period. Entry of infection till the maximum infectivity is called as period of communicability. Entry of infection till the visible symptoms, it's called as incubation period. इसको क्या बोलेंगे बच्चे? Incubation period. Okay. चलो आगे बढ़ते हैं. Now HIV positive mother. HIV are talking and question. HIV positive mother who is taking in an ART, antiretroviral therapy treatment. She delivers a full healthy baby with a birth weight of 3 kg. What is the ideal birth weight of a baby? 3 kg. If it is more than 4 kg, we call it as macrosomia. Now in the baby we started ART just after the 4 hours of delivery. What is the level of prevention of the baby here? Now you know guys, we have 4 types of prevention. We have primordial, we have primary, and we have the secondary and tertiary. Okay. Now depending upon the pre-pathogenic or the pathogenic phase. Now pre-pathogenic, before the disease, we can go for primordial and primary. Once the disease is there, we can go for early, secondary and late tertiary. Good. Now the question here is, the mother is positive. That means the risk factor is there, but baby is not positive. So when a risk factor is present, you try to stop the disease to occur. That is which level of prevention? That is not a secondary, that is a primary level of prevention. Okay, Akhil? If a question is that the baby is also positive and we are starting the treatment in the baby, that is early diagnosis and the treatment, then it goes to the secondary level of prevention. But in this condition, the baby is healthy, the birth weight is normal, okay, baby does not have HIV, but the risk factor is present. What is the risk factor? HIV positive mother. So जब भी risk factor present होगा and you try to stop the disease to occur, that is at which level of prevention? Primary level of prevention. So let's discuss first what exactly is primordial, what exactly is primary, secondary and tertiary. So my dear students, we have 2 phases. We have pre-pathogenic phases. Sir, we have pre-pathogenic and we have pathogenic. We have pre-pathogenic and we have pathogenic. Okay. In pre-pathogenic, we have primary level of prevention. We have primary level of prevention and we have primordial. Okay. We have right first primordial and then primary. Anyway, we have primordial and primary level of prevention. Okay. In pathogenic, we have early secondary and we have late tertiary. Early secondary and we have late tertiary. Okay. Now level of prevention. Okay, the first one that I've discussed was primordial. Sir, what is primordial level of prevention? It means there is a, when you prevent the occurrence of the risk factor, you try to stop the risk factor to occur. That is which level of prevention? Prevention of occurrence of a risk factor. Okay, for example, if we'll not change the water of the cooler every 3 days, 5 days, what will happen? After a week, the mosquitoes will come over there around the cooler. Okay, so mosquito is a risk factor for malaria. So if I'm changing the water of this cooler every day, what will happen? Sir, the mosquitoes are not gonna come. So you try to stop the risk factor to occur. So changing the water of the cooler outside is a which level of prevention? It's a primordial level of prevention, because if I'm changing, mosquitoes are not coming. So that is a primordial level of prevention. Now the mosquitoes came. Okay, now you are using the mosquito net for the prevention of the malaria, for the prevention of the mosquito bite. Okay, so risk factor is what? Mosquito, and you are trying to stop the risk factor, you are trying to stop the disease to occur in presence of the risk factor. That is a which level of prevention? That will be a primary level of prevention. So primary level, using mosquito nets as a which level of prevention? It's a primary level of prevention. Vaccines are which level of prevention? Primary level of prevention. And my dear students, here we have a risk factor. HIV positive mother is a risk factor. Baby have a disease? No, sir. We are starting the prophylactic treatment. We try to stop the disease to occur. For that particular condition, what is the level of prevention? It is going to be a primary level of prevention. Is that clear, bacho? Yes. Now, my dear students, I will ask one more simple question from OB-GYN only, because yes, you have studied. Now, in OBS-GYN, we have studied that we have an active management of third stage of labor. So what is active management of third stage of labor? So that the complications which occur in the third stage of the labor, like uterine inversion, postpartum hemorrhage, we need to try to decrease the chances of this complication by doing uterotonic agents, by going for delayed cord clamping, or by going with the control cord traction or Brand-Andrews method for the removal of the placenta. Okay, now I am using a uterotonic agent drug oxytocin, which we give after the delivery of the shoulder. Okay, so what is a level of prevention? Using oxytocin in active management of third stage of labor is a which level of prevention? Using oxytocin, students, using oxytocin in active management of third stage of labor is a which level of prevention? Tell me this. Using oxytocin is a which level of prevention? Oxytocin in active management of third stage of labor is a primordial level of prevention. Yes, sir. Sorry, it's a primary level of prevention. Why? Risk factor is there. But when you use this oxytocin as a treatment, is a which level of prevention? Sir, early diagnosis and treatment is always secondary level of prevention. Is that clear? So as a treatment, secondary. Prior to that, prophylaxis, primary level of prevention. Okay, clotrimazole prophylactic, PJP में chemoprophylaxis is a which level of chemoprophylaxis is a which level of prevention? When prophylaxis is a primary, but yes, as a treatment, chemoradiation is a secondary level of prevention. Is that clear? Yes, so write it down. So primary level of prevention means the prevention of disease. It means prevention of disease in presence of risk factor. Prevention of disease in presence of risk factor. Okay, then we have secondary level of prevention. So what is secondary level of prevention? It means early diagnosis and treatment. Now, we did not change the water of the cooler every week, every 3 days. We did not put any mosquito nets. Now finally the mosquito came and bite. Now first you will have the symptoms of malaria. For that you are going to hospital. In hospital, what will they do? They will take a peripheral blood smear, they will go for rapid diagnostic tests. So all this diagnosis and the treatment they will give, because patient will have a malaria. So this early diagnosis and treatment is a which level of prevention? Sir, it is a secondary level of prevention. So change the cooler, change the water of the cooler, primordial. आपने risk factor को नहीं आने दिया. अब risk factor आ गया. You are using mosquito nets. You are trying to prevent yourself from a malaria, from the bite. Is a primary level. Now mosquito ने bite कर दिया. Now you going for the diagnostic test. You are going for the investigations and the treatment. This is all a secondary level of prevention. Is that clear? Is that clear, बच्चे? Yes. Is that clear? Early diagnosis and treatment. Okay. And then followed by that we have tertiary level of prevention. What is tertiary level of prevention? What is tertiary level of prevention? It is management of complication. It is management of complication and disability. Management of complication and disability. Clear? Now what are the phase? We have, this is pre-pathogenic. This is also pre-pathogenic. This is early pathogenic. And late pathogenic. And late pathogenic. Clear? Okay. Now classical examples. Tell me about the examples. Vaccines are which level of prevention? Remember, you already know vaccines are primary level of prevention, sir. Vaccines are primary level of prevention. Okay. Next, pap smear is a which level of prevention? Investigations are secondary level of prevention. That is a secondary level of prevention. Mammography also as a secondary level of prevention. Okay. Change of the water in cooler every week. You try to prevent the risk factor to occur. That is going to be primordial level of prevention. Okay. Use of mosquito nets. That is going to be secondary level of prevention. That is going to be secondary level of prevention. Clear to everyone? Now my dear students, the question can be asked that if a patient is coming with a painless hematuria, okay, patient has a history of working in a dye industry, and you know that occupational cancer associated with the dye industry is a bladder cancer, है ना? Benzidine, exposure to benzidine or aniline dye causes a bladder cancer, and the presentation of a patient having a bladder cancer is painless hematuria. ठीक है? Now we are using a BCG vaccine in bladder cancer as well. So BCG vaccine here is a which level of prevention? Now you know vaccines are the primary level of prevention, but in case of a bladder cancer, using BCG vaccine is a which level of prevention? Tell me this. It is a which level of prevention? What will be your answer, bache? It's a which level of prevention? Sir, using BCG vaccine in treatment of bladder cancer is going to be yes. That's a primary, because the risk factor is present. Okay, use of mosquito nets is a secondary, it's a primary, because risk factor is present. You try to save yourself from a disease. Dr. Ashik, secondary. Yes, it's going to be secondary level of prevention using BCG vaccine in treatment of a bladder cancer. All the vaccines are primary level of prevention, remember that, but BCG vaccine using for bladder cancer is a secondary level of prevention. Okay, remember that all the investigations that we do is a type of a secondary level of prevention, whether that is HRCT, mammography, pap smear, MRI, they are a secondary level of prevention. Treatment going on is a secondary level of prevention, early diagnosis and treatment. Okay, and disability limitation, for example, clutchers in the polio. Clutchers in the polio is a which level of prevention? That is a tertiary level of prevention. That is a tertiary level of prevention. Okay, now let's discuss about the STD kits used for the treatment of group painful vesicles leading ulceration or the vulval area under the given program Suraksha. Now the National AIDS Control Program or the National AIDS Control Organization, they started a service called as Suraksha Clinic. Okay, now this Suraksha Clinic gives a service related to the sexual and reproductive health. Now it usually gives a treatment for all the people who are having the sexually transmitted infections or genital tract infections. Now this Suraksha Clinic, in which they follow the syndromic approach. Sir, what is this syndromic approach? Now this syndromic approach means that the treatment is given based upon the symptoms, not on the diagnosis. Now how to define that? Sir, if a patient is coming to me with the complaints of an vaginal discharge. Now a patient is there with the complaints of a vaginal discharge. Now this vaginal discharge can be anything. Now based upon the previous session, we discussed that if a patient is having a creamy discharge, you go with the bacterial vaginosis. If the patient is having somehow greenish discharge, you go with the trichomoniasis. If a patient is having curdy cheese, cottage-like discharge, you go with the candidiasis, right? But in as per the Suraksha Clinic, you don't particularly fully diagnose the patient. So whatever the patient is complaining, symptoms, okay, we give the treatment based upon the symptoms. Okay, if the patient is coming now with a vaginal discharge, we give the kit green containing cyclopentazole and fluconazole and prescribe to the patient. We do not exactly diagnose whether this discharge is a candidiasis, bacterial vaginosis, trichomoniasis. So this is what we call what? Syndromic approach to the patient. So right, treatment, mention it right, treatment is given on the basis of symptoms, not on basis of diagnosis. Is that clear? So that is syndromic approach. Clear? Now, as per the Suraksha Clinic, we had 7 kits before, but the recent update we have 8 kits. Now, any patient coming to me with the complaints of a urethral discharge. Now, a patient coming to me, doctor, with the complaints of urethral discharge or with the complaints of cervicitis, what is the kit you are going to prescribe? The kit that we're going to prescribe is kit 1, which is gray color. The kit that we are going to prescribe is kit 1 gray color. Okay, kit 1 gray color. Okay, yes. Now what are the medications inside the kit 1? Anyone in the comment section? What are the medications inside the kit 1? Yes, we have cefixime and azithromycin. Okay, so any patient coming to me with the complaints of an urethral discharge or cervicitis. Before in kit 1, anorectal discharge was also there, but that anorectal discharge is now kit 8 brown. Okay, now kit number 2, second one, any patient coming to me with the complaints of vaginal discharge. Any patient coming to me with the complaints of vaginal discharge. So what is the kit we are giving? The kit 2, which is green color. Kit 2 green color. Okay, patient coming to me with the complaining of vaginal discharge, I'm giving kit 2 green color. And what are the medications inside the kit 2 green? It is fluconazole and cyclopentazole. It's fluconazole and cyclopentazole. Okay, then remember the sequence WBR, that is white, blue and red. That's white, blue and red. The same sequence, the discoloration in which condition? Medicine mein. What is the sequence of the discoloration? Which phenomena? Raynaud's phenomena. ये भी याद रखना बच्चे. Raynaud's phenomena. Question was asked in the PYQ. Sir, what is the drug that we use? Drug of choice or treatment in case of Raynaud's phenomena? The answer is going to be calcium channel blockers. The answer is going to be calcium channel blockers. So WBR, gray, green, then WBR, white, blue and red. So all these are for the genital ulcers, but depending whether the genital ulcer is herpetic or non-herpetic. Okay, if non-herpetic, white and blue. If herpetic, red. But white is going to be responding to the penicillin, but if a patient is allergic to penicillin or resistant to penicillin, then kit blue is given. So right, white, blue and red is genital ulcers, non-herpetic, which is responding to penicillin. Kit 4, genital ulcer, non-herpetic, allergic to penicillin. Okay, and we have kit 5 red. It is genital ulcer, herpetic. Okay, and usually what's the drug? Acyclovir. Okay, first we have cefixime and azithromycin in the kit 1, followed by that green color we have kit 2, vaginal discharge having fluconazole and secnidazole. Followed by that we have kit 3, white color, non-herpetic, which are responding to the penicillin. And if a patient is resistant to the penicillin with a non-herpetic genital ulcers, we prescribe kit 5, kit 4, which is blue, and genital ulcers herpetic, we prescribe kit 5 red. Patient complaining of a pain abdomen, lower abdominal pain, or PID, usually we prescribe kit 6, yellow color. Okay, we prescribe kit 6, yellow color. Patient complaining of inflamed nodes, or we can write inguinal bubo or inflamed lymph nodes, we're gonna give kit 7, which is black color. And followed by that kit 8 is going to be brown color, and it's update. Okay, they can ask the question from this. It is for the anorectal discharge. Can you tell me what are the medications in the new kit? Anorectal discharge. Yes, for anorectal discharge, doxycycline. And what are the medications inside the kit 8 brown? Tell me in the comment section, guys. We have discussed what are the medications for kit 8 brown. What are the medications for the kit 8 brown? Doxy and, yes, started with C, cefixime. Very good, very good. We have doxy and cefixime. Very good. So it was all about 8 color coded kits. Now here, painful vesicles, that means herpetic genital ulcers leading to the painful ulceration over the vulval area. Genital ulcer, painful, herpetic. The answer is going to be red color, but which one? A, B, C, D. So the answer is going to be kit 5 red. They will also mention kit 3 red, but you should remember that red color is kit 5. Red color is kit 5. Clear to everyone? Clear to everyone? Yes? Yes? Chale. Can we move to the next part? Yes, sir. We can move to the next part. Chale. Which phase of the clinical trial checks the efficacy and monitors the adverse reaction of a new drug? Which phase of the clinical trial checks the efficacy and monitor the adverse reaction of a new drug? Now let's discuss about the clinical trials and the phases. Okay, now we know before starting a drug we go for a clinical trial. Okay, now first preclinical trial we usually start on animals. Clinical trial on animals. Okay, then we have phase 0. We'll do microdosing. and this microdosing we do on healthy humans, or HHV you will write, healthy health volunteers. Okay, followed by that in phase 1 we go for safety and toxicity of drug. We'll check the safety and toxicity of drug. Okay, in phase 2 we check efficacy, phase 3 we are going to comparison between the existing drugs. There is comparison with existing drugs, and phase 4 we check the long term side effects. Phase 4 we check the long term side effect. Remember one more thing guys, RCT is done in which phase? Randomized control trial, RCT is done in which phase? RCT is done in phase 3. Okay, now release of drug in the market after which phase? After phase 3. Sir, maximum tolerated dose of a drug is evaluated in the toxicity of a drug, the safety of a drug is checked in phase 1. Post-marketing surveillance, that is phase 4. Longest phase, again phase 4. RCT is done in phase 3. Most important phase when compared to the existing drugs, the drug should be good enough, efficacy should be good enough. Okay, when compared to other drugs, it is phase 3. Maximum drug failure, which is seen in phase 2. Okay, maximum tolerated dose, phase 1. Okay, so it's all about the clinical trials, bache. Now sir, the question was about the efficacy of the drug. The efficacy of the drug is checked in phase 2. The efficacy of drug is checked in phase 2. Clear? The efficacy of drug is checked in phase 2. Clear to everyone? Yes, efficacy of the drug is checked in phase 2. Is that clear to everyone? Yes? I think this is enough for the part 1. Any doubts in the comment section? Rest will do in part 2. Or you guys want to continue, guys? Update me in the comment section. Yes, all clear? Okay guys, anyway I'll be delivering this full PDF. I'll not skip anything, whatever, all the probable topics. Okay, so make sure that you go through all these topics. Okay, and then further we'll do rest in the yes, half is almost done. We have almost 90 slides. We are done with 43, so half is almost done. So the rest will continue in the part 2. Okay, thanks for being interactive. Day after tomorrow we'll be having a part 2 around 1 p.m. Okay, I will finish rest everything in the part 2. Okay, PDF part 1 part 2 I'll be both sharing in the MeduHub channel. Is that clear? Thank you for being interactive, all of you guys. Okay, so revise OB-GYN part 1, part 2 as well, and PSM part 1 as well. So we are left with PSM part 2 and the pediatrics from my side. Okay, and meanwhile, if you have any doubts, okay, feel free to ask. Okay, ping me in the Telegram. Your doubt should be study related. I always say this. Okay, wherever any difficulty, you're always welcome. Okay, so study, revise, and be confident. Okay, and trust me guys, you are gonna pass this exam. Just 20 days to go almost. Okay, 21 days, and followed by that you're gonna be great doctors for sure. And join me in this side of fence. Okay, so my best wishes are with you. Read, again I'm telling you, be focused, don't compare at the end moment with anyone. Okay, and get this exam done. Okay, I wish you all the best. See you in the part 2. And if any topic you are not good at, please do write me in the Telegram. I will add all those topics in the part 2 in a concise manner. So make sure that you all join on Saturday. Okay, till then, good luck, take care, see you guys.